Mommy, can I hug you? Mom, can I hug you?
Mm-hmm. Oh, what are you doing? I'm probably put this over that side. Hola, hola. How are you guys doing? Captain Kirk, Regius, Bopa. Oh, let me go ahead and share this live. Jackie Burton, Marcia, Shiny Eyes, Wendy Wen. How are you guys doing? I'm trying to share the live. So remember to go ahead and share up the live. All right. Invite a few persons over. Oh. Fayakush, how are you doing? Thank you for liking up the live. Shiny Eyes. Oh, you see, doing great. Okay, nice, nice. How was work today? Hi, JD. How are you doing? And if you're joining in, all right, so we are on TT as well as on YT. On YT, I think nursing. All right, you can follow me over there, subscribe to my page, and follow me on TT, TikTok, I think nursing one. All right. And today we're going to do some study questions. So definitely go ahead and share up the live, share the page, invite 1 and 2 persons over so they can come and join us. All right. Shiny Eyes is saying I'm on holiday going back in September. Okay, okay. Nice, nice, nice. Enjoy. Angela, welcome, welcome. All right, JD, take back him comment over here. But thank you so much, JD, for tuning in. All right. Yes, so like up the live a little bit. And that will help with getting other persons over to the page. All right. So if you're new here, I'm Stacy, Think Nursing. All right, I'm a nurse. I work in the emergency room. I also work as a house call nurse practitioner. And yeah, I'm trying to do content creation, or I'm doing content creation. I want to do it full time. I want to talk with a little bit more nurses, sit and hang out, you know, with persons in the community. I want to give back. I also want to help other persons who are transitioning and, you know, future nurses in their career. All right, so definitely go ahead and follow me, subscribe to my page. And if you have any questions, you can always come back and, you know, you can go ahead and just leave them in the comment box and I will answer them as best as possible. or you can also DM me as well, and I'll answer whatever questions. So if you're, you're a nurse in a foreign land and you want to transition to the States, you don't know how, or if you're transitioning, but you just need somebody to talk to, I am here. So you can feel free to go ahead and leave any questions or any concerns, and I will definitely try to answer them. All right. Shiny Eyes says, I used to do practical nursing. I really love it. Okay, so you say used to. What are you doing now, Shiny Eyes? All right, and we'll try to see if we can aim for, well, Fire Kush, I don't know how much we're aiming for today in terms of likes. All right, the more likes, the more persons get the live. All right, so that's all is needed. You just tap the screen, give the video a thumbs up, get other persons on, and that's all. Hi, Genesis Beltran, how are you doing? 5K. All right, so I'm gonna start off with 5K for our questions and answer tonight. Let's try to make it very interactive. All right, let's try to make it very interactive. Answer the questions, even if you don't know, just guess. Let's pretend as if we're in the exam and we have to choose an answer. All right, so we're gonna try to just choose the smartest, answer on the paper. And remember, we're gonna be thinking like a nurse. What would you do on the spot? All right, those are the ground rules for today. I'm a teacher now for the past 22 years. Okay. I wanted to do teaching, as my second option. So this is just working out pretty nicely for me because I like to, I like to talk and I like to help others. And yeah. Indian, thank you for the follow. All right, so where are we following from, or where are we watching from on YT here? If you don't mind, just say hi. I see 8 persons on the live. Just say hi over this side. All right, so I say I have this thing I wanted to read a little bit, and I say I'm gonna be doing 3 hours. I'm gonna commit 3 hours one day out of the week with about 5 to 10 persons. The first 5 persons who inbox me, and we can actually study together. I have 3 persons already. I'll try to take 5 more persons. So if you really want to study with me, or if you want a smaller group, then definitely feel free to reach out to me, and then from there I will also have packages, but we'll talk about that later on. Just inbox me and see where you are in terms of with getting into one of those small groups, and then from there. All right, but I definitely will commit 3 hours per day. Not per day, 1 day per week with a few persons, and then from there we'll eventually get more persons under this thing and see how well I can help others to get their NCLEX or their RENR, which is the regional exams for the Caribbean. All right, Kalisha, welcome. How art thou? Yeah, tap the screen. That's all we'll be asking for today. All right, I'm not needy. So just tap the screen to get things going. And we're at 2,000. So I'm going to read a little thing here that I have regarding answering the NCLEX question. So they have this thing called prioritize, which is a mnemonic. And I will definitely take a picture of it and put it in my WhatsApp group. So persons who are going to be a part of that little group can go ahead and look at it. All right, I'll try to run through it for about 15 minutes. So you can have a better understanding. I did got this book from, it was my recruiting company that gave me this book. And I found these tips very helpful. So I'm definitely going to have you just take a look at it. And then from there, all right, so they said that prioritizing strategies for the test question. So the definition of prioritizing is to select the client who is most likely to experience problems or ill effects if not taken care of first. So that's the mindset you're going to go into the exam with. The question that nursing graduates are faced with is, how can I prioritize when all of the clients need to be assessed first? We have organized several strategies below using mnemonic or the mnemonic priorities to assist with answering test questions. So the word priorities, this word priorities here is what they're using as a mnemonic to help with guiding how to answer your NCLEX questions. All right, so the first one is the P, where it says prioritize. you're looking at assess the first, assessment is the first step in the nursing process. So every time you have a question, always go with assess, all right? You always look with that. And then it says the nursing process provides a basics for your decision on your test questions, just like it does in clinical. The first step in the nursing process is to assess. However, do not jump to the answer of assessment, all right? If assessments were given already in the stem of the question, the answer would not be to assess. So if you already see assessment findings or data in the question itself, the answer is not going to be for you to assess. It's going to be something else, all right? If there were no assessments given in the stem, then indeed the priority would be to assess. And that's what we were talking about the other day. If you see a question and you don't know where to start, always go with your ADPI. Your assessment, diagnosis, planning, implementation, evaluation. Always go with that. If you're talking about anything else, always start with safety, because that's what we're trying to maintain, all right? The safety of the patient. Then they go on to R, which is to review, which is review if Maslow's hierarchy of basic need is priority. All right, and then this says, remember, physiological needs is higher priority than teaching or psychosocial, all right? So always look at your physiological, findings. Look at those, the physiological needs. The airway, breathing, circulation are critical physiologic needs, which are also at the base of Maslow's hierarchy of needs. So if you're not using assessment, assess, you're using the ABCs, all right? This also applies to questions evaluating the psychosocial need. While these have not changed, do remember that the American Heart Association has changed the sequence of CPR from ABC to CAB. All right, external cardiac compressions, airway, breathing, circulation. All right. Then you go on to I, which is identify the client who is unstable or highest risk for developing complications. And remember, we're using priorities, the word priorities, to help with guiding us with the correct answer. All right, it says when the nurse has several clients to provide care for, the ABCs are critical physiological needs. Oxygenation is immediate and is a concern if physiological changes, that is their vital signs, their skin color, oxygen saturation, or there's a change in the patient's mental status. All right, which indicate hypoxia. Selecting airway, however, is not always the best answer. For example, if a client has been depressed and start presenting with more energy, giving away favorite possessions, and has a plan to hurt self, the priority is gonna be safety. All right, so because safety because of the risk for suicide. Let's say the alternative option in the question is to select a client with COPD who is asymptomatic. The answer is still gonna be the client who is at risk for suicide. All right, so always look at your ABCs and your safety. So safety is always gonna be one of the top answers that you're looking for in almost all of the questions. All right, this is an acute safety issue and the client with COPD is chronic with no new symptoms. Note, this strategy went back to Maslow's hierarchy of needs, all right? Do not read into the question and give client any airway problem if this is not an issue. So whatever you see on the paper, that's all I'm asking you for. So just go ahead and use your safety, your Maslow hierarchy, your physiological needs, all of those. Focus on that. So if it means you're gonna go ahead and review your hierarchy, the Maslow's hierarchy of needs, definitely go ahead and write it down. So every time you see a question, you're looking at that. Thinking about, okay, is this a question that is requiring me to answer based on the physiological needs? This is a question that's asking about, safety itself. So everything you're going to be doing is always going to be about safety. All right. Then O, let me try to talk a little bit faster. O is to organize priority nursing interventions based on the key concept. If the stem of the question provides you with assessment data, then it will be important to analyze and determine what is the priority concept or issue of concern. The key concept or issue will help you decide what the priority actions are to implement. Is a question about Maslow's hierarchy of needs, or is it about ABC, which is the airway, breathing, or circulation, or is it a physiological or psychological or psychosocial needs and or the management of care, and they have risk. So when you reach down to O, you're looking at that risk. Recognizing the limitations of staff, infection control, safety, medication administration, and keeping the client and the environment safe. All right. Then they say R is to remember to think about what is the desired outcome. If a nursing action has already been implemented in the stem of the question, then the question may be asking you to determine if the desired outcome was met, or to evaluate the effectiveness of the care of action. That is, if, so for example, you give the medication, did you have a desired response to the medication? Always connect the desired outcomes to the information in the stem of the question. For example, if a client with CHF has bilateral rails and receive LASIK, the desired outcome is the lungs will be cleared on auscultation. Urine output is going to be greater than 30 mils per hour, is not desired outcome. All right. Then I is to identify the standard of practice. Scope of practice and standards of practice are often the focus of the question. The question may be asking if the standard of practice was met. If it may be asking if the nurse needs to intervene, or what is appropriate to delegate, or did the administration of medications follow the 8 rights of medication administration. And then the T is the trend, compare and contrast client's response. Information in the stem of the question or in the distractors, which are the options, may require you to compare and contrast current assessment to previous ones. You may need to determine if there is a trend and if it is trending towards the desired outcome. For example, the blood pressure, which is 176/89 and is now 135/78 after receiving a beta blocker, indicating there is a trend to the desired outcome. In contrast to this, another trend may be indicating a potential complication for a post-op client, such as a heart rate of 70, respiratory rate of 14, and now the heart rate is 104 and a respiratory rate of 24. All right, this may be indicating a problem with bleeding requiring an intervention to prevent further complications from occurring. All right, 1 second. Yes, Ariane?
Can I bring the sunglasses to school?
No, you need to go to your bed. Bedtime, bed.
Wait, tomorrow?
Bed, no, bed.
Tomorrow?
All right, and then I has to do with infection control, and they said this is very important to the safety of the clients and healthcare personnel. The test questions may ask the following: what are the necessary infection control precautions for prevention and the spread of disease, to include how to avoid communicable diseases or even activities such as room placement, hand washing, steps to donning personal PPE. E has to do with environmental safety, and S is to synthesize all the information and review. All right, so I will definitely take a picture of this so you can have it, so you can, just read through it at your own pace and have a better understanding as to how to go about with answering your questions. Because I think the information here was very, very informative, and I think you guys will benefit definitely from it. All right, Danny, big up yourself. Hail Marcus, welcome, and all of the persons who are rolling out. Thank you for tuning in. All right, so let's get into the meat of the matter. All right, we're at 5,000. Let's start off with some questions. All right, so the first question we have here is, an older adult with chronic pain refuses opioids. Best nursing response for you. All right. A, you must take your medication to avoid suffering. I remember you just choose the answer that is most appropriate. So you're going to write it A, B, C, D. All right. In the options down below. In the comment box down below. All right. So A is gonna be you must take your medication to avoid suffering. B is to tell me more about your concerns with opioids. C, we'll try NSAIDs, they're always safe. D, pain is normal with aging. So if you have a patient who is refusing, they have chronic pain and they're refusing their opioids, what would have been the best response here for the nurse? Hale Marcus is saying A. And A, the answer on A is you must take your medication to avoid suffering. Do we have anybody else with any answer? What about on YT? Try give us one. All right, so going once, going twice. All right, so the answer is gonna be B. So A, Marcus, yeah, B is gonna be the answer. You always want to try to ask the patient to explain a little bit more, explore why, you know, they're having the feeling about, you know, not wanting to take the medication. A is asking you to basically, well, A is saying you must take the medication to avoid suffering. Like, that's not gonna be the best one. All right, and we'll try NSAIDs. They're always safe. That is incorrect because, you know, NSAIDs put you at risk for bleeding. So you definitely don't want to be, you know, giving that patient or cause damage to your kidneys. So definitely you don't want to say that, and they're not always safe. All right, there's no medication that is always safe. And then pain is normal with aging. No, it's not. All right, so the best answer is going to be B, where you explore the patient. Always try to talk to the patient to hear what's happening. All right, but don't dismiss them. Don't force them to take their medication. They have a right to refuse, and that's just it. All right, but it's just your responsibility to just find out a little bit more about why they don't want it. All right, which findings suggest delirium, not dementia? And do we know what delirium is? So whenever you have any sudden change in, like, you know, a patient's mental status, it can be because of different things. Then usually that is what basically delirium is. Sometimes they probably take a medication, they probably have a UTI symptoms, they're acting strange, you know. So you always want to explore the cause of their confusion or their change in their mental status. So with this patient, which findings suggest delirium and not dementia? A, gradual decline in memory. B, confusion that developed in hours. C, poor judgment over several months. D, difficulty recognizing family for years. Which answer do you say? Hi, Unbroken, how are you doing? So which one is delirium? Someone that is having gradual decline in memory, which is A. B, confusion that developed in hours. C, poor judgment over several months or difficulty with recognizing family members for years. Fire Kush says B. Do we have anybody else answering? Just one more answer. Let's try to give Fire Kush a little run for him money. B. Kalisha says B. And definitely, El Marcos says A. The answer is going to be B. So anything that develops suddenly, sudden onset, is going to be delirium. Anything that has been going on for a long time is something else. And based on the answer here, confusion that developed in hours is going to be more to delirium. All right. Any decline in memory that is, you know, taking place over time, sometimes it's related to dementia. Poor judgment over several months is the same. And difficult to recognize in family member for years. You know, basically we're hanging out in that same zone there. All right, so delirium is equal to acute or sudden, and it's usually reversible. So once you identify the underlying problem and you treat it, the patient come back to being themselves. All right, with dementia, it's progressive, it's gradual. Once you have, you know, the insult or the damage or the changes, there's no, you know, no comeback from it. All right, it's just progressively getting worse. Which intervention is the best to prevent UTIs or urinary tract infections in older adults? Is it A, restricting fluids at nights? B, encourage cranberry juice and adequate fluids? C, encourage frequent bubble baths? Or D, use indwelling catheter for convenience? Which option do you think is correct? If you want to prevent UTIs, which option would you suggest to a patient? Restricting the fluids at nights, encouraging the cranberry juice and adequate fluids, encourage frequent bubble bath, or use an indwelling catheter for convenience. All right. Anybody on YT? Want to try? Firecush says B. Okay. Kalisha says D, which is use indwelling catheter for convenience. No. Firecush is correct with the encouraging the cranberry juice and adequate fluids. All right. So always start off with the simplest of things. All right. So restricting fluids at night is not gonna cause you to, not have UTI. At night, it's just gonna prevent you from waking up, putting you at risk for falls and all of those things. B, encouraging cranberry. Cranberry is pretty good. And you also want to encourage a lot of fluids, which is going to help with flushing out that bacteria there. Encouraging frequent bubble bath. No. All right. You don't want to be encouraging the bubble bath. And then the use of indwelling catheter for convenience is a no-no. Whenever you can avoid introducing anything into the body, always stay away from that, because once it goes in, it's a portal for infection. All right. So you don't want to use a catheter just because I feel like I don't want to get up and go to the bathroom. So I'm going to put a catheter in now. All right. You're fine, El Marcus. You are fine. You're fine. Thank you so much for tuning in. All right. So hydration and hygiene prevents UTIs. Catheters do increase, your risk for UTIs. Which medication combination increases fall risk most in the elderly? All right. I think we did this question the other day. We did a question like this. Which medication combination increases fall risk mostly in the elderly? So it's either lisinopril and acetaminophen. You have B, which is warfarin and simvastatin. C is going to be lorazepam and antihypertensive. And D is going to be the metformin and aspirin. Which of the combination, A, B, C, D, is going to put this patient at risk, or the elderly patients at risk? Just a Girl says C, which is the lorazepam and the antihypertensive. Do we have anybody else who would want to try on YT or on TT? One more person. So the option lisinopril and acetaminophen, which is A. B is warfarin and simvastatin. C is lorazepam and antihypertensive. And D is going to be the metformin and the aspirin. Hail Marcus says D. All right. So A is definitely not it, which is the lisinopril and acetaminophen. B is not it, which is the warfarin and the simvastatin. All right. Lorazepam and antihypertensive, both are, one is a sedative and the other one is going to give you like dizziness. It can also cause orthostatic hypotension, cause your blood pressure to drop. So definitely those two combinations you wouldn't want to give. Lisinopril and acetaminophen, the lisinopril can cause your blood pressure to drop as well, but the Tylenol or the acetaminophen will be fine. All right, so you still want to observe your patient because of all of those side effects. But based on the combination that they provided, a sedative and an antihypertensive are two medications that are going to cause dizziness. It's going to cause your blood pressure to drop. And with the elderly, you don't want to have that happening. All right. The simvastatin is a cholesterol medication. It's not going to cause any form of dizziness or anything like that. All right.
Can I bring the sunglasses to school?
Yes, you can.
Yay.
Sorry about that. All right. An older adult with terminal cancer refuses further chemotherapy. This one sounds like similar. Oh, so okay. So older, let me just go with it because not everybody was here the last time. All right. So an older adult with terminal cancer refuses further chemotherapy. The nurse should A, encourage alternative therapies instead. B, document the refusal and notify the provider. C, continue to schedule treatments. And D, to convince the patient to reconsider. Which of those would you say is the best option for this patient? So Claw is saying B, okay, which is document the refusal and notify the provider. Just a Girl is saying A, encourage alternative therapies instead. Another person is saying B, which is document the refusal, which is actually correct. Yes, so B is actually correct, which is document the refusal and notify the provider. All right. Should never go ahead and force any patient to, take anything, regardless of what is happening. All right, always just document why they don't want it. Let the provider know. They have a right to refuse treatment. So you can't go ahead and say, go schedule another treatment for the patient. No. If they just don't want it anymore, you know, let them just have their own. Nothing is wrong with exploring why, but, you know, just make sure you don't force them into getting treatments that they don't want. All right. So always go ahead and remember to respect their autonomy when it comes on to their care. Definitely claw. All right. Which statement is concerning in an older adult? I nap during the day. B, I don't enjoy my hobbies anymore. I wake up early and I take a walk every morning. All right. Which statement is concerning in an older adult? I nap during the day. I don't enjoy my hobbies anymore. I wake up early, or I take a walk early every morning. Claw is saying B, I don't enjoy my hobbies anymore. Shiny Eyes is saying that as well. Do we have anybody on YT? And welcome, welcome, welcome. We're doing some NCLEX questions, so tune in and just share your answer down below. B for sure. Okay, so definitely B. At any time you see where persons are losing any form of interest in anything, especially if it's something that they, you know, once loved, then definitely you want to evaluate that patient for depression and then eventually suicide, you know. So definitely look at that. Pressure injury. Which intervention helps prevent pressure ulcers in bedridden older adults? All right. Massage the reddened areas, which is A. B is reposition every 2 hours. C is to restrict fluids and apply heating pads to bony areas. So which of those in terms of preventing pressure ulcer? So we have B, reposition. Okay, okay. And Shiny Eye says V. I think she's saying B. Okay, definitely you want to go ahead and reposition every 2 hours. All right. Massaging the reddened area, you don't want to do that. It's going to cause pain. It can cause further breakdown or skin breakdown, depending on how fragile their skin is. You don't want to restrict fluids because they need their fluid. And applying heating pads to bony areas, no, you don't want to be that cruel nurse. You understand? So definitely turning them frequently prevents with, you know, skin breakdown and, you know, massaging or anything to applying heat. Go ahead and avoid that. Up and running. Welcome, welcome, Watchman. And thank you, guys. Let's try to see if we can go up to 10,000 likes. It's 10,000? Yeah, man. 10,000 likes on the live here. All right. So just tap the screen. Tap the screen. I'm trying to figure out how to give over here to people to get the sounds. And I don't know how to get it on my thing. But anyways, I will eventually one day. Yeah, so like up the live. But how are you guys on YT doing? Haven't seen anybody saying anything. Unbroken, are you still there? All right. So I know somebody had said they wanted some questions on the elderly. So definitely we'll be doing that as well. A lot of those today. And I have some select all that apply questions as well that, you know, we will be going through. All right. So nice. Thank you for doing that. So let's go to more questions here. A home health nurse suspects elder abuse. What is a priority action? All right. So home health nurse suspects elderly abuse. What is a priority action? A is to confront the caregiver. B is to document findings and report according to policy. C is to ask the client to confirm abuse in front of the caregiver. And D is to ignore unless client asks for help. Which one is the best answer for you? Is it A, to confront? Okay, so I see B. Document the findings and report according to policy. C is to ask the client to confirm, you know, the abuse in front of the caregiver. And D is to ignore unless client asks for help. All right, so definitely the answer is going to be B. All right, because remember, as healthcare workers or nurses, we're mandated reporters. So if you see it, you're supposed to just report it. No questions asked. You understand? Confronting the caregiver, you don't want to be doing that. All right, because most of the time they're going to deny it. And yeah, you don't want to confront them. Have the appropriate persons deal with that. All right. Ask the client to confirm abuse in front of the caregiver. Sometimes you probably make the mistake and go ahead and ask, and the patient, even though they know they're being abused, they're gonna tell you that no, them are right. The caregivers them are doing good. So definitely don't ask them. If, so for example, you're thinking about or you want to ask the patient some questions, you can always have the caregivers go ahead and just do something. Have them step out of the room or something, and then you can quietly ask if everything is okay. But never in front of the caregiver, because they're not going to be answering correctly. All right. Ignoring unless the client asks for help, that's a no-no. All right. And always remember to document objectively. Whatever you see is what you document. It's not how you feel. Whatever you see, you document it, and that's it. All right. An 82-year-old Shiny Eye says, yes, they will say they are okay out of fear. Definitely, definitely, definitely. And even though sometimes, you have some persons who will not want to answer to certain things, because especially if you see, they get a fracture and you're trying to get information and the relatives are not wanting to leave the room for you to go ahead and ask certain questions. Depending on the location of the fracture, depending on the markings, whatever it is, use your piercer and think of it. Is it possible for, sometimes I hear people talk about the cigarette butt burn a patient, and the location of it is just so weird. It's just so random. You're wondering what happened, or the iron, brand them somewhere. Always think of abuse first, depending on the location of certain things. All right. An 82-year-old is 1 day post-op surgery. Which finding requires immediate action? All right. Pain at the incision site, rated 7 out of 10. B, which is a temperature of 99.4. Confusion and agitation. Or D, refusing to eat breakfast. So it's a post-op patient, elderly patient. Which patient is concerning for you or requires your immediate attention? Claw is saying C. Anybody else? Okay. Achemdom is saying C as well. All right, so based on the answer there, the patient that is confused and agitated is going to get your attention. Pain at the incision site, it's 1 day post-op, so there's going to be some pain. All right, temperature 99.4, not really a temperature yet, but you want to keep an eye on that. Refusing to eat breakfast, probably the patient don't have any appetite, you understand? So out of the 4 patients, the confusion and the agitation is something that you need to address. It can be because they're having delirium, they're hypoxic, they have infection going on. Definitely find out what it is and address that situation. All right. Which side effect of anticholinergic medication is especially concerning in an adult, an older adult? So you have an older adult who is on an anticholinergic medication. Which of these side effects for the medications are concerning? The patient having dry mouth, blurred vision, constipation, and urinary retention, or D, which is tachycardia. And do we know what how to identify the side effects for the anticholinergic effects versus the anticholinergic medications? Anticholinergic medications. So which side effect of anticholinergic medication is especially concerning for the older adult? All right. So you have dry mouth, you have blurred vision, constipation and urinary retention, and the tachycardia. All right. So there's a mnemonic that usually you use for, your anticholinergic and your cholinergic side effects. All right, and they talk about sludge. You remember the sludge mnemonic for the cholinergic medications? Okay, so Claw says urinary retention, yes. All right, and the constipation. So they have the sludge mnemonic, SLUDGE, where it talks about salivation, lacrimation. So all of those cause like tearing. Salivation, lacrimation, urination, diarrhea, GI cramps, emesis, and meiosis. All right, so the sludge, everything with the eyes, the heart, the lungs, GI, bladder. So you have salivation. So your medications are like your neostigmine, physiostigmine, pilocarpine, bethonecol, which is used for urinary retention. All right, so when you think about cholinergic, you're thinking about wet, and anticholinergic is going to be dry. So any medication that you take that dries up your mouth, then that's the anticholinergic effect from it. All right, so sludge is for the wet one, which is a cholinergic, and then the anticholinergic you're using hot as hair. I don't remember if persons remember that one. Hot as hair, dry as a bone, blind as a cat, red as a beet, mad as a hatter. All right, so you tend to have fever, dryness, the eyes become so dilated, you know, you're so blurry in terms of your vision, the skin is red and flushed, and the brain, you're confused, you're delirious. All right, so those are two ways to remember them. Anticholinergic is the wet one, the dry one, and the cholinergic is the wet one. All right. So the answer we said would have been C, which is the constipation and urinary retention. Tachycardia is going to be the fast one, which is the wet, and blur vision is wet as well, and the dry mouth is going to be... The dry mouth is which one? The dry mouth is the anticholinergic. Dry as a mouth. Constipation and urinary retention. Okay, especially. Okay, so out of the dry mouth and the constipation and the urinary retention, the best option will be the constipation and urinary retention. All right, because there's a risk of bowel obstruction, UTI, and delirium. All right. Please, can you read the question again? Which side effect of anticholinergic medications is especially concerning in older adults? A is going to be the dry mouth. B is the blurred vision. C is constipation and the urinary retention. And D is tachycardia. So which of them is most concerning? And then we said that with the anticholinergic, those are the ones with the dry side effects. All right. Yes. So you're correct, Claw. The C is the correct answer. All right. The dry effects, which is the dryness. You might have the dry mouth, the no sweating, dilated pupils, flushed skin, confusion, delirium. And then the wet one is the cholinergic, which is the pupils, they become like, you know, constricted. You might have the bradycardia, increased secretions, diarrhea, and you have a lot of urination. All right. A terminally ill patient chooses hospice care. Which nursing focus is most appropriate? A, aggressive curative treatment. B, comfort and symptom management. C, preparing for rehabilitation. D, encouraging extensive diagnostic testing. So which of them is the focus of hospice care? All right. Is it aggressive curative treatment? B, comfort and symptom management. C, preparing for rehab. And D, encouraging extensive diagnostic testing. All right, so B. Marvin says D. Okay, so the answer is going to be B, comfort and symptom management. All right, so you want to ensure that they have, you know, quality of life. You're not planning on curing anything. All right, so definitely hospice care is about comfort, dignity, and quality of life. All right, so definitely aggressive curative treatment is not a no-no for hospice care. All right, remember the patient is terminally ill. And comfort and symptom management, preparing for rehabilitation. No, if they're usually terminally ill, you know, you're not rehabilitating them to go back into, you know, the world like that. And then encouraging extensive diagnostic testing. They're terminally ill, so it doesn't make sense to do a ton of testing on them. So that's going to be a no-no. All right. This one. Any other questions in the meantime? So pain control measures is priority. Definitely. Let me get back up here. Yeah, my finger touched on something a while ago. So I have I'm trying to find the number that I am at. Okay. Older adults with oxygen at home should be taught A, store oxygen tanks under blankets. B, avoid wool blankets or smoking near oxygen. C, use petroleum jelly for dry lips. D, keep oxygen near gas stove. I think this is like a repeat question as well. B, avoid wool blankets or smoking near oxygen. Okay. So older adults with oxygen at home should be taught store oxygen tanks under blankets. B, avoid wool blankets or smoking near oxygen. Use petroleum jelly for dry lips. Or D, keep oxygen near gas stove. So we have B, okay. Smoking is a no-no. Definitely, smoking is a no-no. All right, so the answer is B. All right, avoid wool blankets or smoking near oxygen. Oxygen supports combustion. Fire prevention is always priority. All right, and then also you want to talk about the petroleum jelly, because petroleum is also, you know, a risk for fire as well. All right, but definitely the one that is priority here is gonna be B. All right. So all of those are important to tell them, but make sure you tell them about avoiding, you know, the smoking at that time. Which is the most important nursing action when giving opioids to an older adult? All right. Is it encourage fluids to prevent constipation, monitor respiratory rate closely, instruct to avoid grapefruit juice, or D, give only at night? Hi, Marvia. Yes, thank you so much for tapping up the live. All right, so which is the most important action when giving opioids to older adults? Encourage fluids to prevent constipation. B, monitor respiratory rate closely. C, instruct to avoid grapefruit juice, and give only at nighttime. And what we know about opioids, it's the crisis we're having nowadays. Okay, so we have monitor respiratory rate closely, definitely addendum. Do we have anybody else with any other answer? So encourage fluids to prevent, monitor respiratory, definitely. You always want to monitor the respiratory rate, because you know with opioids or narcotics, then definitely there's a risk for, you know, respiratory depression. So you want to monitor that because it's a life-threatening risk. Encouraging fluids to prevent constipation. Yeah, you can, but sometimes they probably need a little bit more than the fluids because everything in the elderly tend to slow down a little. So a lot of times you want to encourage them to get a lot of fibroids, sometimes stool softener as well. Instruct to avoid grapefruit juice. Give only at night. No. All right. They affect the respiratory muscles. Definitely. Shiny eyes. Not sure the question. So, which action is the most important nursing action when giving opioids to an older adult? All right. So, encouraging fluids to prevent constipation. Monitor the respiratory rate closely. Instructing the patient to avoid grapefruit juice, or give only at night. And the answer is going to be the one with the respiratory rate. You always want to monitor the respiratory rate because of the risk for respiratory depression. All right. And then we have another one here. Which environmental modification best reduces fall risk in the elderly at home? Dimming the light at night. B, scatter the rugs to prevent slipping. C, grab bars in the bathroom and non-slip mats. And then D is to use high firm bed. Which of these will reduce the fall risk in a patient or elderly patient at home? So we have C, okay. C, okay, which is grab bars in the bathroom and non-slip mats, okay. Definitely, that's it, all right. Dimming the light, nighttime light, you can dim the light, but what if the bed is still high? You know, what if they don't have, they don't have on their socks, depending on what is going on, you understand? Dimming the light is not gonna cause them to not fall, because especially if they're getting out of bed, the bed is a little bit high, then even though the light is dim, they're still gonna be at risk for falling. Scatter the rugs to prevent slipping. No, you want to make sure you remove some of those rugs, all right? Use high firm bed. High is the word there. You definitely want the bed in a lower position, all right? So grab bars and non-slip mats are very, very important when it comes on to fall precaution for patients. An Alzheimer's patient is wandering at night. Which intervention is best? Restrain with a soft mitten. B, provide a safe, structured environment with night light. C is to administer sedative every evening. D, lock the bedroom doors. Which option is best? If you have an Alzheimer's patient who's walking around on the floor and, you know, you want to make sure that they're safe, what is the best option? To restrain them with the soft mittens, provide a safe, structured environment with night light. C is to administer sedative every evening, and D is to lock the bedroom door. Okay, so Marva says B. China says D. All right. Kalisha says B. So B is the answer. All right. Provide a safe, structured environment with night light. You don't want to restrain the patient with any soft mitten, or you don't want to restrain the patient any at all. All right. That's a last resort. All right. And redirect them. Definitely. Providing a safe, structured environment with night light is pretty good, and you redirect them. Administering sedative every evening, that's a no-no, all right? Not because the patient is wandering, it doesn't mean they're not gonna knock them out completely. So definitely you don't want to do that, all right? Because then that is gonna cause more risk, or it's gonna be more risk for fall. And then you don't want to lock the bedroom doors, because when you lock the bedroom door, how are you gonna see the patient? So the patient is just gonna be walking and the door is locked. Patient can stumble and fall in the room there as well. So definitely that's a no-no. All right, you want to open the door so you can always keep an eye on them. So B is to provide a safe, structured environment, all right, with night light. Which food is best to recommend for an older adult at risk for osteoporosis? Is it white bread? Is it spinach and fortified milk, caffeinated coffee, or processed meat? Which of these food is gonna help a patient who has osteoporosis or at risk for osteoporosis? B, okay. So spinach and fortified milk. Kalisha says B, Marva says B. Okay, nice. All right, and so a lot of times this patient, because of their low bone mass, they tend to have like pathological fractures. They're very, very prone to fractures, so you definitely want to give them, rich foods that has calcium. They need foods high in calcium. So your spinach and fortified milk. White bread. What white bread have? Ton of carbs. Caffeinated coffee. That's a no-no. Processed meats, you know, you're gonna be having a lot of proteins, but you don't want to be packing up patients with processed food as well. All right, so calcium and vitamin D rich foods help your bones, so definitely you want to encourage that. When you're assessing pain in a patient, an elderly patient, which tool is best for a patient with dementia? So you're trying to find out from that patient if they're having pain. Remember, the patient is confused, you know, so you definitely want to go ahead and see if this patient is having pain. How would you assess? Are you going to be using the numeric rating scale where it says, on a scale of 1 to 10, how bad is your pain? 10 being the worst and 1 is, you know, Are you going to be using that scale? Are you going to be using the Wong-Baker faces scale? So they have the little faces, and then they're going to touch on whichever one. Flack and Pain, definitely. Do you want to use that one with them, or the visual analog scale? Which of them is the best one you're going to be using? And the Flack, the faces, okay. So faces is going to be which one? Wong-Baker faces we're talking about. So B, okay, so Wong-Baker faces. So the Flack, okay, so the Flack scale is the one that helps with behavioral. So, hold on. I'm trying to... Okay, so the Flack scale is a behavioral pain assessment tool used to evaluate pain in nonverbal patients by observing specific faces or behaviors rather. So the F is for face, L is for legs, A is for activity, C is for cry, and D, well, and the other C is consolability. All right, so that is what the Flack scale is going to be assessing. All right. The Wong-Baker is the one that we usually commonly use, right? The one with the little face. So a lot of times we use it for children whenever we ask them to go ahead and tell us how, you know, how bad is their pain, and they tell us if it's a smiley face, a sad face, a crying face. Definitely. Hi, Anthony. How are you doing? So definitely you will use that one. So the behavioral pain assessment tool is going to be the Flack one. All right, that's the one they have here, because they're already confused. So if you tell them to select the one with the correct face, they're more than likely just going to press on one because they don't understand what you're saying. All right, so definitely it's you who is going to have to observe them. What is their face looking like? You know, their legs, what is happening with their overall presentation, and then give it a grade. So it's a scale, and you give them a number, and then from there you tally it, and then it will tell you if they're having like severe pain, if they're having little to no pain, whatever it is, and then from there you can go ahead and treat them or medicate them. All right, so it's a behavioral pain scale that is used when verbal reporting isn't reliable. And I think that's the one they also use in like ICU as well. So sometimes like you have your patients who are intubated and they're probably not fully sedated, like, you know, completely out. Sometimes depending on if they're having pain, that is one way they can actually use to go ahead and say, okay, then this is what is happening. All right. Oh, the flag will work well then. Yes. It's actually Flack. F-L-A-C-C. All right. The nurse should improve communication with hearing impaired older adults by, so if you have an older adult who is like hearing impaired, how are you going to improve your communication with that person? Are you going to be speaking loudly into the ear of that patient? Are you going to be reducing background noise and facing the patient? Using complex medical terms, or talk quickly to reduce fatigue? Which one would you choose? So you have a patient who is, you know, impaired, all right, they're not hearing so well, but you're trying to talk to them. What is it that you're going to be doing? So BBB, okay, reducing background noise and facing the patient. Yes. So if you have on your mask, you're probably going to have to pull it down as well a little bit, you know, talk so they can hear, so they can read as well. Definitely reduce the background noise and face the patient. Speaking loudly directly into the ear, sometimes you do that and the patient still not hear. Because which one is it? Is it conductive hearing loss they have? Let's look it up. Yeah, so a lot of times they tend to have one of those hearing loss, and so it's hard for you. If you talk too loud, they won't hear it. So if you talk at your regular tone, you know, then a lot of times they do hear what you're saying, even though they do have that hearing loss. Use simple language and allow time for them to process. Definitely. All right, you don't want to use complex medical terms, not only to the elderly, but a lot of times to almost all of your patients them. All right. And then talk quickly to reduce fatigue is always a no-no. All right. So me, you hear me talking here, I always have to be like slowing down, slowing down, slowing down. All right. So face the patient. Clear, slow speech helps with them understanding. All right. Why are older adults more prone to skin tears? All right. Is it A, because of increased collagen? B, decreased subcutaneous fat and elasticity. C is overproduction of sebum. Or D, thickened epidermis. So why are the older adults more prone to skin tears? Is it because they have too much collagen? Is it because they have decreased subcutaneous fat and elasticity? Okay, and C, which is overproduction of sebum, or D, which is thickened epidermis. So Marvia says B. Okay, nice. Do we have anybody else on YT? Okay, Achendum says B. Kalisha says B. Nice. Okay. Yes, so as you get older, you tend to lose a lot of your subcutaneous fat, all right? That's why we have this thing called, you know, when you get the skin get loose. Yeah, man. We all experience it. We will all experience it one day, all right? So your body become loose. That's what they say. Your body become loose. So you lose the elasticity on your skin, and so you are more prone to skin breakdown, tears, you know, when it comes on to you feeling cold. Yeah, man, you don't have any cushion, you don't have any extra fat down there, any subcutaneous fat to help with that, and so you experience all of those. All right, so thinning skin and losing your fat tends to lead to fragile skin and increases your risk for tear. There is also a reduction in sebum, but is it gonna be causing you to have more skin tears? So of the two, so although that one, you have well, it's not overproduction. You don't really have overproduction though of the sebum. All right, but you will have the sebum even if you have the sebum there. Oh yeah, so you have the reduction in the sebum. So I don't think that would be like, you know, the main reason why, or the highest risk if you were gonna probably compare two answers. All right. Shiny eyes, thank you. Oh Lord. Yeah, that was just confirming. Yes, confirm the answer B. All right, so definitely. All right, so let's go on to the best intervention for constipation in the elderly is the best intervention for constipation in the elderly is A, encourage high fiber diet and fluids. B, limit activity to prevent strain. C, give laxatives daily. And D, to restrict fruits. Which of them is the best intervention for constipation? So we have encourage high fiber diets and fluid, limit activity, give laxatives, and restrict fluids. We have two answers here. A, anyone on YT wants to answer? Okay, nice. So definitely A is gonna be the answer. You always want to start out with the simplest of things. Tell them to eat more fibers, anything like, you know, corn, your wheat products, anything that has a lot of rough edges. Encourage them to go ahead and do that and increase their fluid intake as well. Limiting activity to prevent strain. You never want to, no, you're not gonna limit their activity. Still want to have a decent amount of activity throughout the day. All right, I don't know if that is going to help with preventing strain, but you don't want to reduce activity. Giving laxatives daily. You don't want to be having patients on laxatives, because what is going to happen is that if they get too loose in terms of the stool, then they'll be losing out their potassium and all of those electrolytes. So definitely start with anything that is less invasive. Yes, start with anything that is less invasive, things that, you know, you can do without too much. All right, restricting fruits. You don't want to restrict people them fruits. Let them eat up them fruits and eat it as a part of their, you know, their diet. So diet and fluids and mobility are the first line. Laxatives only if needed. So if you notice that you've been giving all of these, or you're encouraging and they're eating that amount and it's not really helping, then it's okay to start your laxatives. All right, but once you start passing the stool, you want to let them know stop, because some persons will just continue taking it and they're having those loose stool and losing all of their potassium, their sodium, their chloride, and then putting their body at risk for, you know, electrolyte imbalance. All right, so definitely educate them on that. Which vaccine is recommended for older adults annually? Is it hepatitis B, influenza, polio, or smallpox? Exactly. Thank you for that one as well, Claw. So remember, so laxatives, you have to prescribe that one as well. So definitely, if you're there as a nurse and you're educating them, you cannot tell them to go ahead and take laxatives. You know, if the answer says like laxatives per order, you know, the order is already there. And if you never had something like, you know, the fluids and the fruits and all of those things, then probably that would have been one of the answer. All right, but if you're going to be there as a nurse and they're having the constipation, you always want to go ahead with, you know, your diet and all of those things that you can do. You can explain to them, educate them, encourage them, and then from there, if it's not working, you go and get an order for laxatives and medicate them. All right, so the answer here is going to be B. Which vaccine is recommended for older adults annually? The influenza. All right, so annual flu protects the vulnerable older adults. Hepatitis B, you know, you get that from donkey years. All right, so we definitely have that one. Polio from donkey years. Smallpox, I don't know if some people still getting that, but yeah. All right, but the one that is recommended for the adults annually is the annual flu shot. All right. Teddy Bear, thank you for the live. All right. So, which order should the nurse question for a hospice patient with dyspnea, which is the shortness of breath? So, which patient should the nurse question for a hospice patient with dyspnea? All right, I remember the hospice patient, usually a lot of times, you know, they have a terminal illness, and the goal is not to cure them, you know, or try to rehabilitate them. So which of the patient or which of these order would you as the nurse, if the doctor said to you, okay, then this is what, you know, I'm ordering, this is what I want you to do for the patient, which of them would you say, but doctor, this patient is hospice, you know? So is it gonna be low dose morphine, oxygen therapy, IV antibiotics for pneumonia, fan directed at face? So which order should the nurse question for a hospice patient with dyspnea? Low dose morphine, oxygen therapy, IV antibiotics for pneumonia, or fan directed at face? So Claus says C and Chendom says D. Okay. All right. So low dose morphine, you want to question that because the patient is on hospice. So it's about pain management, you know, palliative care, support. Oxygen therapy. Nothing is wrong with giving oxygen to a patient. All right. You don't want them to be there gasping for air in front of you. And you have the little oxygen where you can just put on and, you know. So definitely you want to question that. IV antibiotics for pneumonia and fan therapy. Those are the ones that are up for debate. Fan directed at face. You don't really need to ask a doctor to do that one. So Achendum, I don't know if you meant B, you know, but you said D, but fan directed at the face, you know, I want to question that. Because as soon as the doctor turned him back, me turn the fan, you know, the other direction. You understand? But the one that is there that is, you'd question is the IV antibiotics for pneumonia. And that's what the answer here says. You are treating the pneumonia. So because you're curing it, then that's why the answer is C. All right. I know a lot of times we probably have, because I have a lot of patients that are on hospice, and may I tell you, yeah, they get the full 9 yards just to see. You understand? So not me order it, but I see it being done. So I think probably if you're in the real world, sometimes you might see certain things done. Like, say, for example, they're treating for a UTI, they're treating for, but if in reality, or based on what, you know, in terms of hospice care, the criteria for hospice care and management, the answer here would definitely would be the IV antibiotics for pneumonia. So that's why I was saying, even though you probably have years of experience working as a nurse, don't go in there and think like, you know, you're a nurse, or don't go in there and say, oh, you know that they do this, because a lot of things we're doing, yes, even though we're doing it, sometimes we're doing it for, you know, the family. you know, the family, we're doing it for the patient, because we are saying, well, look, IV antibiotics is not going to hurt. So definitely they'll go ahead and do that. Treating a UTI is not going to hurt. We go ahead and do that. But in reality, if you're going to be doing the question, don't think of what we're doing, what the textbook says. The criteria for hospice patient, or why the patient is there, is not for you to cure them, not for you to rehabilitate them. You know, you just providing comfort. All right, they're there for palliative care, you know, end of life treatment. Definitely do that and answer the question based on that. All right, not what you're doing currently. All right, so hospice focus on comfort, not curative antibiotics. All right, so it might sound harsh, but it's just the reality of, yeah, hospice care. Best, exactly, don't act alone. Definitely. All right, best non-pharmacologic intervention for insomnia in older adults. All right, so if a patient has insomnia, them can't sleep at night time, you know, probably they stay up in the daytime, we don't know. But a patient has insomnia, what is the best thing you do for that patient that doesn't have to do with medication? Give a sleeping pill every night, encourage daytime naps, maintain regular bedtime routine with relaxation, or D, limit physical activity. Which of them is the best non-pharmacological intervention for insomnia in older adults? C, welcome disciple of God. 2, Marvel saying B, encourage daytime naps. C, A, okay. All right, so Angela, remember, non-pharmacologic intervention. So A has to do with giving a sleeping pill. All right, so whether or not, okay, addendum C. All right, so even if you're getting the sleeping pill over the counter, all right, non-pharmacologic, so you don't want anything to do with any prescriptive medication. All right, so definitely the one that says maintain a regular bedtime routine with relaxation. So you want to do, like, you know, your sleep therapy, all of those things. You definitely want to be doing. Giving a sleeping pill every night is a pharmacologic, all right, intervention there. Encouraging daytime naps. You don't want them to sleep at daytime. You understand? So you try to keep them up at night, at day, and then you try to get them to sleep at night time. But this patient is having insomnia. So if they're sleeping all the entire day, there's a high possibility in the night they're not going to be sleeping. All right. So you want to maintain a regular bedtime routine with relaxation techniques for them to go ahead and sleep. And limiting physical activities are no-no. All right. You want them to be active, especially during the daytime. Get them beat out, get them tired in the day, and then they can sleep comfortable at night. All right. So definitely choose C, because sleep hygiene is first line. Some of the doctors give them sleeping pills. Yeah, definitely. But based on the question here, it's saying non-pharmacologic intervention. If we had asked for pharmacologic intervention, then definitely that's the only one that has a sleeping pill. So you would go with that one. Yeah. So it would be just C. Well, as I said, just C is going to be the answer, because the encourage daytime naps is not going to help with the insomnia. And then D, limit physical activity, is not going to help as well. All right. Which client should the nurse recommend stop driving? All right. Is it the client with mild hearing loss? Is a client with cataracts causing blurred vision? The client with corrected vision using glasses? Or the client with arthritis in the fingers? All right. Yes, definitely, Chiny. All right. So which of the patients you would recommend telling them, no, not go around the steering again? Which one? B. All right. So definitely, Claw, please, with NCLEX question, please, NCLEX tip, always read and understand every word of the question. Yes, that's why I said whenever you're answering the question, just read the question and say, I'm in the real world. Yeah, read the question and make sure you're answering it based on what they provide. Don't put anything else in the question. The question is just beer, and that's all they're asking. The answer is on the paper. All right. So which client should the nurse recommend to stop driving? The client with the mild hearing loss, the client with cataracts that is causing blurred vision, client with corrected vision using glasses, and client with arthritis in fingers. And we have B, okay, B. Yes, nice. So the answer is definitely gonna be, hi Darlene, thank you so much for tuning in. Okay, so the answer is gonna be B. All right, and as I say, I am on YT at the same time, ThinkNursing. That's the handle, so you can go over there and follow me, subscribe to the page. The full video is gonna be, well, the live is already over there, so just in case you miss it here, you can always go onto YT and look up the live as well, and follow me on TikTok at ThinkNursing1. All right, so the answer definitely is gonna be the person who has impaired vision. All right, the one with the cataracts causing blurry vision, that's the one. Thank you, Claw. Thank you. That's the one you definitely want to tell to stop driving. All right, they need to clear up that cataract first, and then they can go back around the steering wheel. So a client with mild hearing loss, you know, they can always get a little, you know, hearing aid, and it's mild, it's not severe. So definitely you don't have to tell them to stop driving right now. Achendum, thank you so much for the follow as well. Client with corrected vision using glasses, the vision is already corrected. A lot of us are wearing glasses because we have vision problems, but we're still driving, we're still able to see, and in terms of safety, you know, that is still going to be priority. You're not driving and then causing accidents. And then the client with arthritis in the fingers, people still can hold on to the steering and everything, so you don't have to be worried about that. But in terms of the one that has blurry vision, who cannot see, you definitely need to tell them to stop. It's a no-no. All right, so definitely that one is unsafe for the patient as well as for others. I'm leaving this refresher course for me. You've done the exam before, right, Shiny Eyes? I don't know if I'm leaving this or I'm liking this refresher course. Oh, you're loving this refresher course. Okay, thank you. I'm trying to do it like, you know, I'm going to try to see if I can do it twice per week on Tuesdays and Thursdays starting next week. And then from there, we'll try to do a few hours, you know. And then, as I say, I'm going to be doing some smaller groups. So just in case you are wanting to be a part of the group, you can always go ahead and inbox me. For persons on YT, definitely you can go ahead and text me as well. Same thing on, well, you guys can inbox me on TikTok. All right, so we can have smaller groups just in case, you know. I know the group right now is not that big, but definitely the smaller groups where we can have a little bit more of a personal, you know, thing going. That would be nice for some persons. All right, but if not, we can still hang out here, and I'm still gonna be doing the live either way in the week. So yeah, not a problem, Achendum. Sasha, I'm good. How are you doing? I would use it. Yeah, definitely. All right, older adults are at risk for dehydration due to A, increased thirst mechanism, B, decreased renal function or impaired thirst sensation, C, high metabolic reserve, D, increased muscle mass. Why do you have your patients, your elderly patients, at risk for dehydration? Is it because of the increased thirst mechanism? Is it B, because of decreased renal function and impaired thirst sensation, C, high metabolic reserve, or D, increased muscle mass? B, okay. B, okay. B, nice, definitely. So the decreased renal function and impaired thirst sensation, while, you know, as you age, all of those reduce. So definitely, you know, you're going to be at risk for. So aging reduces your renal concentration ability as well as your thirst. So a lot of times the patients will just be there and, you know, they probably just don't want anything. So you have to encourage them to drink their fluids. All right. Increased thirst mechanism, that's the opposite of what is happening in the elderly. High metabolic reserve, their metabolic reserve is not high as they get older. Increased muscle mass is a no-no because their muscle mass decrease, hence why they're loose in the skin. And so a lot of times they are at so much risk for dehydration, hypothermia because of all of that. All right. What is the nurse's best teaching for preventing orthostatic hypotension in the elderly? All right, and if you know what orthostatic hypotension is, then you'll be able to answer the question properly. All right. So, is it A, change position slowly from lying to standing, avoiding fluids before standing, C, to lie flat after standing, or D, exercise vigorously before rising? Which of these teaching is preventing orthostatic hypotension in the patient? So orthostatic hypotension, a lot of times when you have patients, suddenly getting up, they tend to start having the dizziness, their blood pressure tend to fall. All right. So things like that is when your blood pressure changes based on your position. All right. Orthostatic. Hi, Denise. Welcome to the live. All right, so with orthostatic hypotension, there is a drop in the blood pressure that happens when the person stands up from sitting or lying down. So a lot of times some persons just get up suddenly and then their blood pressure falls. They tend to feel dizzy, lightheaded because of that change in the blood flow. So definitely, you don't want that to be happening. So a lot of times you just tell them to slowly get up, sit at the side of the bed, dangle their legs, all right? And then now you can tell them to rise slowly to prevent all of that, because you can have falls resulting from that. All right, so we have AAA, which is correct. Change position slowly from lying to standing. All right, definitely yes, Shiny. Avoiding fluids before standing. No, lie flat after standing. That's not gonna cause it. Usually when you're hypotensive, you want to tell them to lie flat to help with, getting the blood pressure, the flow of the blood back to the brain, preventing all of that dizziness and everything. No. All right. And then exercise vigorously before rising. Nah. And that goes to every patient who has been lying down. Definitely, Claw. Definitely. You understand? You want to encourage them to slowly rise to prevent orthostatic hypotension. All right. So slow position changes reduce dizziness and falls. So definitely you want to do that. Which environment is safest for older adults in summer heat? Is it A, no fan or AC, windows closed? B, well ventilated, light clothing, hydration? C, dark, heavy blankets for sweating? D, room temperature above 90 degrees. So which environment is safest for older adults in the summer heat? Kalisha says B, B, B. Okay, nice. All right. So remember the summer heat. So the patient already, their skin is already loose. They're so fragile. They're already probably in 70 degrees. They're probably already cool. You understand? So definitely you want to make sure that the room is well ventilated, they're wearing light clothing, and they're, fully hydrated. So which environment is safest for older adults in the summer heat? So the no fan or AC, windows closed? No. They're going to be at risk for hyperthermia. Dark, heavy blankets for sweating? No. Room temperature above 90 degrees? No, you'll be frying these individuals. So definitely you're putting them at risk for stroke. Heat stroke, that is. All right. So you want to make sure that you're getting your cool ventilated areas for these patients. All right. First line intervention, it is B. Definitely. First line intervention for urinary incontinence in elderly. What's the first line? Inserting a indwelling catheter for these patients. Teach bladder training and pelvic floor exercise, the same one we call Kegel exercise. Yeah. So you sit down right now and you're doing your Kegel exercise. Yeah. Is it that one you're going to teach them? Restricting fluids to reduce urgency. Or D, give prophylactic antibiotics. So which is the first line intervention for urinary incontinence in elderly? All right, remember, first line intervention for urinary incontinence in the elderly. So Sam says B, teach bladder training and pelvic floor exercises. All right, do we have anybody else on YT wants to say something? Just a girl says D, which is give prophylactic antibiotics. I think you never hear the question, you know. I think you just come on. So D is where you give prophylactic antibiotics. Do we have anybody else who want to join the fun? Call to hearts. Welcome, welcome, welcome. Kalisha says B, which is teach bladder training and pelvic floor exercises. So the first line intervention for urinary incontinence, always start off with things that are not invasive, all right? So inserting an indwelling catheter is a no-no, all right? You don't want to be leaving an indwelling catheter in because, you know, the nurse can't bother anymore to go and change the patient when the patient pee the bed. Yeah, because we feel as though it's a inconvenience for us. We'll put in a catheter, you understand? Or you just put it in because it's going to make the bed a little bit drier for the patient, things like that. No, remember, indwelling catheter is going to cause, you know, infections, all right? It's a source for bacteria, so you want to avoid anything like that. Teach bladder training and pelvic floor exercise is always a good way to go ahead and do that because, you know, there's always going to be a little leakage. So you always want to strengthen up that muscle there. So your Kegel exercise is always going to be good. Restricting fluids to reduce urgency. You'll tell them, yeah. All right, but you're not going to restrict their fluids. All right, if they're supposed to get a certain amount, let them have it. But once you train their bladder, then eventually, you know, that will help with their incontinence as well. And give prophylactic antibiotics. No, unless the patient has a UTI, then you want to go ahead and give your antibiotics to those patients. All right, but you're not going to just give prophylactic antibiotics like that. If they have a UTI, you give them, unless they're probably confused or, you know, they're having fever and you're thinking that there's a UTI, you want to start that in the meantime, and then you get your urine to see if you've treated it appropriately. But the bladder training and the exercises are the first line. Catheters are always last resort. All right. All right. All right, so we're gonna try to answer some select all that apply. Nobody's favorites. All right, let's try to get the live up to 23. I saw, how far with it? 22. All right, let's try to get it at 23,000. Let's just tap up the live a little bit and then refresh and then come back again. We'll come back again. All right, but nobody's babe. Welcome. Oh, but that is, I've seen her. Just a girl. Okay. Kids for me, invite Real, Reese, Steven, welcome. I see all of you guys. Taddy baby, welcome, welcome. Call to hearts, big up yourself. All right. Denise, you were asking, what is your take on COVID vaccine? You know, everybody have a preference in terms of what they want to introduce into their body, you know. So it's up to you. My take on it is that, what would I say? I took it. Never hurt me. I think it's okay. Just like you take the flu vaccine, a lot of persons take different vaccines to prevent certain things. Like, I didn't see anything that was different. Yeah, so it's, you know, it's just like the flu vaccine for me. Just take it once and that's it. I'm not taking any more. All right, I just take my 2 doses and that's it. So yeah. NCLEX next. Ma'am Hokua. Okay, nice. I know you're gonna pass. All right, so wishing you the best here from the ThinkNursing crew. All right, I know you'll pass. Just don't overstudy too much, you know, on the night before. If you never know it, you're not gonna know it again. All right, so rest yourself, refresh, you know, reset, and go in the exam with an open mind. If you have a little, you know, cheat sheets, nothing is wrong with doing that, but don't take up the big book and go to your bed trying to study. If you never get it, you not get it again. All right. So just go ahead and just sleep it off, wake up refreshed, and go in there with an open mind. And as I say, when you're going to sit the exam, just say it's a perfect world. So every question, repeat, this is a perfect world. There's nothing short, all right? And don't read into the question. And I know you're going to do well, all right? I know you're going to do well. All right, so Darlene on YT saying first time watching here. Not a problem. Thank you so much, Darlene, for tuning in. Remember to go ahead and follow me on YT or subscribe on YT at ThinkNursing. All right, it's one word. If you've missed the live or any of my lives that I've done, definitely they'll be over by YT posted. And there's tons of information over there, all right? And if you're on YT and you haven't started following me on TikTok, definitely come over to TikTok. The people over TikTok, them nice, them fun. You understand? If you want to talk with me, yes. So definitely come over here and chill with us, all right? But I'll try to do my live at 7 o'clock during the week. I'll try to do twice. Well, on Tuesdays and Thursdays, I'll try to do, the study group here. And then from there, we'll, evaluate as we go along, all right? But yeah. Always approach a question as a nurse, read and understand. Definitely. Let me pin that right up there. Okay. All right. So, all right. So we're up to 23,000. Thank you so much, everyone, for tuning in. All right. And if you're new here, I'm a nurse, emergency room nurse, Jamaican, working in the US now as an emergency room nurse practitioner. I love it some days. I do a house call, house call is kind of one of the dirtiest parts of nursing, but I do enjoy it. And I'm trying to do a little bit more study sessions with, persons who are interested or persons who are wanting to do their NCLEX, their RENR exam, as well as I'm trying to build my platform on YT, where I want to talk a lot with nurses here, their day in the life, their transitioning stories, growing up, things like that. That is what I'm interested in. And I want to do a foundation, give back to, my country, as well as by extension, the world. So definitely I want persons to hop on and volunteer when it's time to go back to different places to kind of help out. So things like that. So if you have money and you're watching, if you're rich, just think about my foundation, that I'm planning, I'm working towards. So if you want somewhere to put some of your money, definitely there are different communities in Jamaica and other parts of the world that would benefit from that. And so subscribe to my YT page at ThinkNursing. That's all I'm going to say. All right. So are you going to be a full-time influencer? I don't really want to be like an influencer like that. I just want to have a normal life. I come on the live here. I'm a chat with and I talk, just talk about nursing. I'm live a normal life, and that's about it. I don't really want to be an influencer with the remedy on the back of me, and the long fingernails and all them stuff there. Yeah, I just want to be a regular person doing my life. I go on the road and life is good. All right. I want to be doing a lot of work out there, but I don't really want the influencer kind of thing. Yeah, it just kind of sound, yeah. But either way, yes, I want to do full-time content creation with everything that I am talking about here. All right, let's get back to the questions here. If we're finished, amen. Windsor Basic School will do well with the help. Oh, you're from Windsor? I'm from Asia. Sweetland. Yeah. We got the host. We got Manchester and the host. Definitely. Yes, that's what I really want to do. I want to do that. Yes, that's a vibe I want. I want it to be a case where, we're very open. I want persons to be able to talk with me and not be scared. Yeah, stuff like that. All right, Blessed Kia. Oh, I thought it was Blessed Kia. Blessed K, welcome. All right. Oh, Marvin, you're from Victoria Town. So, Pewsey and them places there. Oh, Lord. Oh, my word. Definitely make sure to go ahead and inbox me, Make sure you go ahead and inbox me so we can get the number and we can chit-chat. All right. Definitely do that. Hold on there. Oh, it's not Marvia, because I went to school with a Marvia. I think she came from down that side, I think. But it's not you. All right, let's get back to, the meat of the matter. All right. So, safety, let's go with this one. Safe medication administration in elderly requires, and this is a select all that apply question. All right. So safe medication administration in elderly requires A, reviewing all prescription and over-the-counter medications. B, monitoring for polypharmacy. C, encouraging double doses if one is missed. D, using the lowest effective dose. And E, assessing renal and liver function. All right. So remember, it's select all that applies. So you have 5 options. If you want to choose the 5 of them, 4 of them, 3, 2, 1. But you have to choose something. All right. So which of the 5 safe administration, medication administration in elderly requires A, reviewing all prescription and over-the-counter medications, monitoring for polypharmacy, C, encouraging double doses if one is missed, D, using lowest effective dose, and E, assessing renal and liver function. So safe medication administration. All right. I think it's A, D, E. Okay. A, B, D, E, just a girl. Okay. So definitely the correct one is A, B, D, E. All right. So for all patients, safe medication administration, especially in the elderly, requires you to review all prescriptive and over-the-counter medications. So if they're taking vitamins, you need to know what they're taking as well because of the interaction with the other medications. You also want to look at polypharmacy. Are they getting multiple medications from different pharmacies? So you want to look at that. All right. Encouraging double doses if one is missed. No, you don't want to do that. All right. If they miss the medication, they take the next dose at, the appropriate time. All right. But you don't encourage them to double up on the dose at that time. All right. Well, if they miss the medication, they take it at the earliest possible time. But if they already take the medication and they're not getting the response, you don't tell them to take another one. You don't double up on the dose. That's what I meant. All right. So that one is going to be out of it. You don't encourage double doses if one is missed. D, use the lowest effective dose. That is something that you always want to start the patient at. And E is to assess renal and liver function. All right. So safe practice, you want to ensure that you're doing their medication reconciliation, dose adjustment. You also want to look at their organs to see if it is functioning properly or, if the medication is causing any damage. So for example, they're on the cholesterol medication, you want to be looking at their liver. You understand? A lot of the medications can cause like renal problems. So you want to look at their renal function to make sure everything is fine when you're giving the medication. But never double dose your patient. All right. So the answer is A, B, D, E. Then the select, wonderful, just, yes. All right. Risk factors for pressure injuries in older adults. So select all that apply. All right. Immobility, incontinence, poor nutrition, adequate hydration, advanced age. So which of these are risk factors for pressure injuries in your older adults? So the patient is at risk for pressure injury because of what? Is it because they're immobile? Is it because they're incontinent? Is it because they have poor nutrition? Is it because they're well hydrated? Or because of advanced age? I know it's going to be hard for, so A, B, C, E. Definitely. All right. So A, B, C, E is the correct answer. So risk factors for pressure injuries in older adults. So just think of the older adult. A lot of times they're not moving around. So they're immobile. So that is going to cause, them to be on one side for too long, giving them pressure also. Incontinence is another one. They're going to pee on themselves. It's going to be moist. Skin start breakdown, especially when they're not moving. So that's another risk factor. Poor nutrition. They're not eating properly. The skin, is, you don't have enough protein and all of those taking place. You're going to have your skin breakdown with all of the pressure and everything that is going on. Adequate hydration is not gonna cause, it's not a risk factor for that. And advanced age, as you get older, as I say, you lose your subcutaneous fat, you have the thinning of the skin, and then you tend to not be able to move properly because, arthritis probably knocking you left, right, and center, or, different things going on. So all of those, immobility, moisture, malnutrition, and aging weakens your skin integrity. And so because of that, those are risk factors. Hydration actually helps with your overall, your skin and preventing ulcers. All right. What nursing actions to prevent aspiration in a client? What are some of the nursing actions to prevent aspiration in a client with dysphagia? And that's the person who is not able to swallow. All right. So what nursing actions will help with preventing aspiration in this patient? Is it to sit the client upright during mealtime? Is it to offer thickener in their liquids? Encouraging talking while chewing? A, B, E. So A is to sit the client upright during meals. B is to offer thickened liquids. Supervise meals. Okay. One more. What about encouraging talking with chewing or placing the food on the unaffected side of the mouth? A, B, D, E. Definitely. Sorry about that. All right, so A, B, D, E is correct. So you want to sit the client, always have the patient in an upright position because this patient is at risk for aspiration, but the patient is already having problems with swallowing. So even though they're probably having problems with swallowing, they've passed their dysphagia screen. They're not choking, they're not coughing while they're swallowing. So definitely what you can do for this patient is sit the client in an upright position when you're feeding them. You want to offer something that will thicken their liquids, all right? So it's not choking, going down too fast and then causing them to be coughing or choking on that. Encourage the patient to be talking while chewing. No, you don't want to be doing that. We're not supposed to be talking and chewing either way, even though we probably don't have dysphagia. All right. Placing the food on the unaffected side of the mouth is okay because sometimes you might have the weakness. You might have weakness on one side. You want to go over the other side. You understand? And make sure you just give them the food from that side so they can always, swallow slowly. And supervise their meals is definitely something that you want to do. All right. So upright positioning, thickened foods, food placement, and supervision reduce aspiration. Talking while chewing actually increases the risk for aspiration in those patients. Hello. All right, so definitely you want to do that. Signs of elderly abuse may include, and this is a select all that apply question as well. All right, unexplained bruises, delay in seeking medical help, hesitation to speak in front of the caregiver, D, well-maintained hygiene and clothing, or E, reports of financial exploitation. So which of these is or are signs of elderly abuse? All right. Is it A, unexplained bruises, delay in seeking medical help, hesitation to speak in front of caregiver, D, well-maintained hygiene and clothing, and E, reports of financial exploitation? So if you see a patient coming in and you notice any of these, what would you do? Would you report it? Or which of them would you report? Because there's a concern. A, B, D, E, okay. A, B, C, okay. Do we have anybody else? All right, and remember this is a select all that apply question. So the one that has unexplained bruises, definitely that would be a concern, especially if you have the smoke. As I said, sometimes you might have the cigarette bud You know, some persons might have different markings with the cigarette. They might have the iron. They might have a bruising at a location, and you're wondering how is it that they did get that, especially if they're bedbound or bedridden, and you notice that they have bruising on their legs or something like that, their back. Definitely, you want to find out a little bit more about that. Delay in seeking medical help. Sometimes you see patients come in and the wound or whatever happened, it happened probably a few days ago, and it's something that probably needed to be evaluated immediately at that time, but they took a while to actually come in. If it's a fall and they have probably like a ecchymosis, you know, they probably have like deformity of the leg, things like that is very concerning. Hesitation to speak in front of a caregiver, a lot of times it's because of fear. So definitely you have to take that into consideration as well. Sometimes, you know, if you're observing your patient, you can know when they're trying to say something to you without even saying it. So just observe them very carefully. And if at that time, as I say, just ask the relative or the caregivers to either go and do something, find something that they can step out of the room and ask the patient whatever is going on. Well-maintained hygiene and clothing. A lot of times when patients are well taken care of, you know, they are looking good. But then you have to remember the ones that are putting on those maintained clothing, them really look good when they come on road. Yes, they put it on to kind of cover up certain things. So you have to be careful as well. So, but even though the question here does have it, you're choosing from all of these questions, these answers rather. And then reports of financial exploitation. Definitely, that is a form of elderly abuse. So you definitely want to look at that. All right, so everything there is correct except the well-maintained hygiene and clothing. All right, based on all the other things, you would suspect elderly abuse there. We need to screen to follow up better. Definitely, fear kill our patients. A lot of times it does. All right, so physical, emotional, and financial abuse signs are present there. Good hygiene is not suspicious. All right, as I say, you can always just look at, especially like their fingernails, because sometimes they probably come in looking real clean, but their fingernails are just looking awful. They're smelling awful. The only thing that is looking good on them is their clothes. So things like that, you just have to take into consideration. Look at, and sometimes you can just look at the relatives them too. You understand? Because if a relative look like, they're $1 million and the patient in the bed look like, $10, then obviously something is off. All right, so definitely evaluate all of those, but know the different types of abuse and how to identify them. Teaching points for orthostatic hypotension prevention. You're gonna do the select all that applies. I think we had one like this. Rise slowly from sitting or lying. Sit at the bedside before standing. Avoid sudden position changes. Increase fluid intake if not contraindicated. Avoid wearing compression stockings. So what are some of the teaching points for orthostatic hypotension prevention? So you have a patient that every time they get up, they feel lightheaded, dizzy, feel like they want to pass out, and the blood pressure just drops. How would you go about teaching that patient or telling that patient, no, in order to prevent all of those signs and symptoms, you definitely want to go ahead and do what? So we have A, B, C, D. So rise slowly from sitting. Sit at the bedside before standing. Avoid sudden position changes. Increase fluid if not contraindicated. Good. What about avoid wearing compression stocking? No. So, okay, nice. Definitely. So A, B, C, D. Avoid wearing compression stocking is not, it's not going to help them. All right, it's not going to harm them. All right, so compression stockings will help the patients, but it's not going to harm them, because in terms of preventing like clots and all of those things, it's going to help them. It's not going to harm them. All right, but in terms of orthostatic hypertension, rise slowly from the sitting or lying. Sit at the bedside before standing. Avoid sudden position changes and increase your fluid intake if not contraindicated. All right, you need the compression stocks for circulation. All right, good. Yeah. And then what are some of the signs of dehydration in older adults? Yeah, we get one of that earlier, but it wasn't all that apply. It wasn't all that apply though. All right. What are some of the signs of dehydration in older adults? And this is all that apply question. Dry mucous membranes, confusion, increased skin elasticity, hypotension, dark concentrated urine. So signs of dehydration in the older adult: dry mucous membrane, confusion, increased skin elasticity, hypotension, as well as dark concentrated urine. So A, B, D, A, B, D, E, good. A, B, D, E, A, B, C, D, E. Okay, so everybody that says A, B, D, E is correct. So when you are dehydrated, you will have dry mucous membrane. So your skin is going to feel dry. Your mucous membrane is just going to be dry. Confusion can happen as well. Increased skin elasticity is a no-no. You're going to have decrease in your skin elasticity. All right, so you tend to have like a tenting, you know, your skin is just like, no, there's not going to be much elasticity there. It's going to be decreased. Hypotension is another one, because if you don't have enough, you know, fluid circulating, your blood pressure is just going to be low. The heart rate is going to be like, thready, low as well. The urine is going to be very dark and concentrated because you don't have much fluids, circulating. So definitely dehydration, confusion, dry mouth, low blood pressure, and dark urine. All right. Skin turgor is less reliable in the elderly. All right. And especially when it comes on to the elderly as well, they already have loose skin, so you can't really use that to tell whether or not they are dehydrated. All right. So that's not going to be one of the best option. All right. Non-pharmacologic pain management for the elderly. Thank you for the follow there. All right. Non-pharmacologic pain management for the elderly. Select all that apply. So it's A, B, D, E, definitely. The C, the one with the increased skin integrity, elasticity, is out. So the non-pharmacologic pain management for the elderly. Select all that apply. All right. Remember the word none. Non-pharmacologic. All right. Pain management for the elderly. Is it A, heat or cold therapy? B, relaxation and guided imagery? C, massage? D, distraction activities? Or E, increasing opioid dose until pain-free? So which of these are non-pharmacologic pain management for your elderly? So things that you don't need a doctor's order to do. All right. Tart Collie, welcome, says B. So it's a select all that applies. So based on all of these, which are the non-pharmacologic pain management for the elderly? Heat or cold therapy, relaxation and guided imagery, massage, distraction activities, or increasing opioid dose until pain-free. So we have A, B, B, C, A, B, C, D. Okay. So the answer is definitely going to be anything that doesn't have E, which is the one that says increase opioid dose until pain-free, because that's a pharmacologic. All right. You have to get an order for that. All right. Distraction activities, massage, guided imagery, relaxation, heat or cold therapy. Those are things you don't need an order for. It's not medication. So definitely you can try any of those. All right. So complementary therapies support pain control. Opioids should be the lowest effective dose and not escalated blindly. All right. So you don't want to feed them with the narcotics until, they say they're pain free. Definitely. You don't want them to be like, All right. Then, okay, let's try to get this live up to 25,000. Wendell, welcome. Just double tap up your screen and like up the live. Ricky, thank you so much for that gift. All right. The blood of Jesus, welcome. How are you doing? How this thing go again? Thank you for tapping up the live. You know what I'm looking for? I'm trying to find. Oh, I think this is it. No, that's not it. Trying to find the. Oh, yeah, man, that's it. That's what I was looking for. my boss. My boss. All right. Thank you so much for that, Rose, and the heart me. Ricky. All right. One magnetic. Welcome, welcome, welcome. All right. All right. So, interventions to promote bowel irregularity in older adults. Select all that apply. All right. Is it, we did something like this already. Let me just run through it. Encourage high fiber foods. Encourage increase in water intake. Promote regular exercise. Administer daily laxatives prophylactically, or encourage toileting after meals. So interventions to promote bowel regularity in older adults. Do you encourage them to eat, high fiber foods, increase their water intake, promote regular exercise, administer daily laxative prophylactically, or encourage toileting after meals? Which one would you say? A, B, everything exactly. Anything that doesn't have to do with the laxative. All right. Let's see. So A, B, C, E. So encourage the high fiber foods, increase water intake, promote regular exercise, and encourage toileting after meals are all things that you can encourage or, help with promoting that. So always go with lifestyle changes first, and then you can always go with, your medication, because you don't want them to be dependent on those medication. All right. So definitely do that. All right, let's try some delegation questions here. I remember you can always go ahead and tell me, what questions you want. If you have questions that you want us to go through, or if you feel as though there's an area that you're weak at, feel free to go ahead and send me so I can prep some questions. Yeah. All right, as well. All right, so let's go with this one. Which task? All right, let's do this one. Which task can the LPN perform for a client with stable vital signs? All right, so remember, this patient has stable vital signs, and it's the LPN. So which task can the LPN perform for a client with stable vital signs? Is it start the IV fluids management? Okay. Is it start IV fluids? A, reinforce teaching about a new diet. C, evaluate response to a new pain medication. D, perform initial admission assessment. All right, so you have a LPN. Which task can they provide for a patient with stable vital signs? B, C. All right, so this is not all that apply, mommy. Reinforce, okay. Do we have anybody else? Hi, Obo, welcome. So which task can your LPN perform for a client with stable vital signs? And mommy says reinforce. Okay, nice. So starting an IV is a no-no, all right? That's for your RN or your, who else can do the IVs? But your LPNs can't do the IVs, all right? Reinforce teaching about a new diet. No, that's a no-no, all right? You have to have somebody do so your nurse is going to do the first teaching, the initial teaching or the initial assessment, IV initiation, all of those things are going to be your nurse, all right? Evaluate the response to a new pain medication is something that they can do, all right? No, they can't evaluate, my bad. The nurse is going to evaluate. E, Marva says E. And perform initial assessment, admission assessment, no, can do. All right, so remember your RN has to do anything to do with education, discharge, initial, things like those. First assessment, your RN has to do. Your LPN can reinforce teaching about a new diet, all right? You can reinforce because it's already been taught by your nurse. So LPNs reinforce education but do not conduct first teaching or initial assessment. IV initiation and evaluation are RN task. All right, so let's just remember that next time. The RN, what's the highest level of nursing? Your DNP. Love note. Hola. All right. So the RN as a newly post-op client and stable client recovering from pneumonia. So she has two patients, a newly post-op client and a stable client who is recovering from pneumonia. Which task can be assigned to the unlicensed assisted personnel, the UAP? 1 or A, assessing incision site for infection. B, assisting the post-op client with ambulation. C, measuring and recording urine output for stable client. D, performing a head-to-toe assessment. So which of those would you delegate to the person who is the UAP, your unlicensed, B and C? Okay. So assisting the post-op client with ambulating or measuring and recording urine output for the stable patient. If you have one to choose, which one would you choose? Assessing the client. So you have two patients. One is a post-op, new post-op patient, and the other one is also recovering from pneumonia. So you're going to choose which one you can assign to your UAP. All right, your unlicensed assisted personnel. So is it the one that you're going to assess the incision site for infection? B, the one that, you're assisting the post-op client with ambulation. C, measuring and recording urine output for the stable client. And D, performing a head-to-toe assessment. So Claus says B as our final. Marva says C. Do we have anybody else? Welcome, welcome, welcome. B and C. Oh boy, you have to choose one. You're in the exam and time is running out. So you have to choose one. Which one would Kalisha says B? Let's see where Obo goes with her answer or his answer. Not so sure yet. All right. So the answer is actually C. All right. The post-op is still critical, but the stable patient is safer. Okay. All right, so C, which answer you had said? C, definitely. So the answer is C. So assessing the incision site for infection. Remember, this is a new post-op patient. So while you're there, you're going to be assessing. All right, so this is a new post-op patient. You're going to be there assessing the incision site. So definitely that's a no-no for your UAP. Assisting the post-op client with ambulating. So that patient is... it did said in the stem where it says newly post-op client. All right, so definitely you want to be the first person to assess. You're going to try to see how that person is ambulating, things like those. So you're going to assist the post-op client with ambulation. You're also assessing, all right, in that little while you're assisting that person. Measuring and recording urine output for the stable client. That is something everybody can do. All right, so definitely measuring and recording urine output for the stable client. The patient is stable. All right. Definitely you can ask your UAP to go ahead and measure that urine output. All right. Performing a head-to-toe assessment. That's a no-no. All right. They can't do assessments. So the initial assessment and all, definitely you have to have your nurse doing it, your RNs doing it. So definitely C, measuring and recording urine output for the stable client. If it was unstable, if it was an unstable client, definitely, that would have changed the game for this patient, and probably your UAP wouldn't be able to measure and record that urine output. But because it says stable client, it's okay for them to go ahead and do that. Post-op is still critical with the stable patient. Yes. All right. So UAPs can measure and record output. Assessment and ambulation for post-op clients require RN supervision. All right. Which task is appropriate to assign to a LPN? Administering IV antibiotics for a critically ill patient, reinforcing teaching about medications to a stable client, performing a neurological assessment for a new stroke patient, developing the care plan. Which task is appropriate to assign to a LPN? Your licensed person, what would that be again? Hold on, they help me. LPN, licensed practical nurse. Yeah. Your LPN. All right, your licensed practical nurse. So which of them you can assign to your LPN? So is it administering IV antibiotics for a critically ill patient? Is it B, reinforcing teaching about medications to a stable client? Is it performing a neurological assessment for a new stroke patient? Or D, developing the care plan? So B, okay, all right. So anything that has to do with reinforcement, they can actually do. Anything that has to do with initiating first assessment, things like those, your LPNs are not able to do it. All right, so administering IV antibiotics for a critically ill patient, definitely you want to do that. All right, reinforcing teaching is something that they can do. Performing a neurological assessment for a new stroke patient is definitely a no-no, all right? And developing the care plan is totally out of it, all right? All right, so LPNs reinforce teaching and administer routine meds to stable clients, but not new assessments or care planning, all right? So definitely remember that. Stable versus unstable clients. So which client is appropriate to assign to your UAP? Is it the newly admitted post-MI patient, your myocardial infarction patient? Is it a client with a tracheostomy on ventilator? Is it a client with stable vitals needing routine morning care? Or a client post-op day 0 with a chest tube? Who is it that is most appropriate for you to assign to your UAP? A newly admitted post-MI client, a client with a tracheostomy on a ventilator, a client with stable vital signs needing routine morning care, or a client post-op day 0 with a chest tube. Marvia says C. Okay, Chinese says C. Okay. We have anybody over by YT, and Achendum says C. Definitely the answer is C. And always just carefully comb through the words, you know, that they're using. Anytime you see anything talk about stable, just go ahead. You know, stable, stable, stable. Always look at those as one of the options for your answer. All right, so if you have a newly admitted post-MI client, definitely you will want to assign that patient to the UAP. Client with tracheostomy on ventilator is definitely a no-no. All right, a client post-op day 0 with a chest tube is a no-no, because you want to make sure you're observing that chest tube drainage, you know, looking for any ear leaks or anything like that. You want to make sure that the patient who is on the trach, you know, with the trach and the ventilator, everything in terms of settings and everything is good. So you're going to always want to be around those patients, all right? But the patient with the stable vital signs who just needs morning, you know, routine care is something that they can assist with, all right? And so that out of all of these 4 patients, that would have been the most stable patient for that person. All right. Which morning task can an RN safely delegate to the LPN? Is it continuous EKG on a client with chest pain? Is it measuring vital signs for a stable client on oral meds? Assessing new onset shortness of breath? Initiating oxygen therapy for acute hypoxia? Yes. All right, so C. Okay, do we have anybody else with any other answer? So which monitoring task can the RN safely delegate to the LPN? So this is a licensed practical nurse. So you have one on the floor, you have your 4 patients. Which of them you're going to delegate and say, hey, can you help out with this patient? So C, I see 2 persons saying C, which is assessing new onset shortness of breath. Want to change your answer, or are you keeping that? So continuous, you have continuous EKG for a client with chest pain. So if the patient is getting continuous EKG, it means that the patient is having active, patient is having chest pain. So they're doing the continuous rhythm check on that patient. B, measuring vital signs for a stable client on oral medications. Definitely you can give that patient to, your LPN. C, assessing new onset shortness of breath. Because it says assess, you definitely won't give that patient to anybody except the RN, all right? And it's a new onset. So you're gonna have to kind of explore a little bit more. D is initiating oxygen therapy for acute hypoxia. So you definitely won't give that patient to anybody else except your RN, all right? Because remember, you're initiating, assessing, things like that. Definitely won't be to your UAPs or your LPNs. It's going to be for your RN. So the one that says measuring your vital signs for your stable client is the one that you'll definitely go ahead and assign to your LPN. All right. Acute assessment and interventions remain the primary responsibility for your RNs. All right. Not a problem, Shiny. All right. Which statement about teaching delegation is correct? LPNs can teach new concepts independently. B, LPNs can reinforce teaching previously taught by RNs. UAPs can explain discharge instructions. And RN cannot delegate teaching reinforcement. So which statement about teaching delegation is correct? B, okay, LPNs can reinforce teaching previously taught by your RNs. Definitely, definitely, definitely. So remember, you can always reinforce. You cannot initiate, or assess. So LPNs can teach new concepts independently? No. All right. Anything that has to do with new initial assessment, is definitely going to be your RN. All right. The LPNs can reinforce teaching previously taught by a RN, definitely. All right, so if you already teach a patient about diabetes, at the start of your shift or the admission, then whenever you assign your patient, your LPN can go over there and reinforce, still talk about, making sure you're eating, your low carb diet, monitoring your sugar, things like that. They can go ahead and reinforce what you've just taught. Your UAPs can explain discharge instructions. No, all right, you're gonna have to be your nurse as well, your RNs as well. RN cannot delegate teaching reinforcement. RN can delegate, all right? They can delegate teaching reinforcement, because when you send out your LPNs, that's what they're gonna be doing, all right? So when you send them to say, okay, then go and do a finger prick or something, they probably patient might be asking why you need to do that. They probably explain to them that they're diabetic and this is what is, expected, and that is basically reinforcing. So the mere fact that you've delegated a LPN to do that job, basically you are reinforcing, they're teaching, they're reinforcing what you've taught already to that patient. All right, so RN cannot delegate teaching reinforcement? No. It's the other way. RN can delegate teaching reinforcement. All right. So LPNs can reinforce teaching, not introduce new material. UAPs cannot teach. All right. Let's go on to this one. Because a lot of times you might be on a floor where you have your LPNs, your CNAs there. So a lot of the questions at times will be around them. Which task can be safely delegated to a LPN? Is it administering IV push medications to critically ill patients, administering oral antibiotics to stable clients, initiating a new IV, or teaching insulin injection technique for a first-time patient? And as I say, always look at the words, comb through each question and the answer and make sure you're choosing the right, the right option. And look at the words carefully, because sometimes the questions are so simple, but we are thinking a little bit deeper than, what it is. So B, administering oral antibiotics to stable clients. Definitely, definitely. Because as I say, administering IV push medications definitely is out of, their scope. And then it says critically ill patients, initiating a new IV, teaching insulin injection technique for a first-time patient is out of it. So LPNs can give routine oral meds to stable clients. Anything that has to do with IV, push, new IV, and first time teaching requires the RN. All right, so definitely. Those are more select all that apply. What time is it? 9:15. All right, let's do a few. I'm gonna do about 10 pharmacology question, and then we'll wrap up because I think we started at 7, right? All right, let's do. All right, so let's do this one. Which insulins can be safely mixed in the same syringe? So which insulins can be safely mixed into the same syringe? Is it your regular insulin and your NPH? Is it the regular insulin and the glarine? Is it the Lispro and the glarine? After 10 for you. Oh, where are you, Marvia? It's after 9 for me. Or the NPH and the detamir. Which of these can safely be mixed together? A, okay, A. Terex, oh yeah, I think you did say it. Okay. So which two? Okay. So A and 916 here, regular and the NPH. Definitely the regular and the NPH. All right. You only can mix a short acting and an intermediate. All right. Those are the only two that can actually be mixed. So only short acting, regular, and intermediate NPH can be mixed. Long acting, which is the glarine and the detamir, are never mixed together. All right. So the two that can be mixed is the short acting and the long acting. And if you were supposed to pull them up in the syringe, which of them would you pull up first? So you're going to be pulling up those two medications. Which one would you pull up first? You'll pull up the regular, okay. The short acting, okay. The regular, definitely. And then, you know, they always say if one is cloudy and one is clear, you always go with the regular clear. Okay, yes. So always go with the clear one and then you go with the cloudy one after, if you don't remember. We don't want to dirty the regular with the NPH. Definitely. All right. A client on warfarin requires further teaching if they state, I will avoid green leafy vegetables. I will use an electric razor. I will report blood in the stool. I can take aspirin if I have pain. So which of these patients or which statement made by the patient would say that, you know, so you never did learn anything today? Which of them would you give further information or education to? D. Okay, nice. All right, because what? Why you choose D? So D says I can take aspirin if I have pain. So this patient is on warfarin. All right, and we already know that warfarin is a blood thinner. And with aspirin is what? D. Both. Okay, blood. Okay. Okay, and said, all right. So the patient is gonna be, you know, at increased risk for bleeding there. And then with the aspirin as well, you know, sometimes it can it causes like GI bleed as well. Causes GI bleed, so definitely you want to avoid that in a person who is already on you know, a blood thinner. All right, so if the patient says I will avoid green leafy vegetables, then they're good. All right, because you're not supposed to be eating too much of a green leafy vegetables with your warfarin there. I will use an electric razor, definitely. I will report blood in the stool, definitely, because as I say, you're at risk for the GI bleed, so definitely you want to report any of those. I can take aspirin. Aspirin increases your risk, so try to avoid it as much as possible. All right, and even clients should not take it unless it is prescribed. And even if it is prescribed, you still want to let them know, you know, about the same thing about GI bleeding and everything. If they're having any bloody stool, if they're vomiting, if their stool looks dark, things like that. All right. The nurse is administering IV vancomycin, which is a priority assessment for this patient. Hearing changes, blood glucose, respiratory rate, and vision changes. So you have a patient who is on vancomycin, which is the priority assessment for this patient. Is it hearing changes, blood glucose, respiratory rate, or vision changes? Respiratory, okay. Do we have anybody else saying anything? So if you have a patient and they're getting antibiotic, and a lot of times there is one specific antibiotic that you hear people always talk about, you know, they have ringing in the ears. And that's the one, I think it's like gentamicin. A lot of times you'll hear they say, oh, just be careful because you might have the tinnitus, the ringing in the ears. So you might have the ototoxicity because of that. So you might have damage to your ear. And so you always have to just be careful. So vancomycin is the same thing. You want to look out for any changes in their hearing. All right. Blood glucose is not like a priority for this one. Respiratory rate or vision changes. So vancomycin can cause ototoxicity, which is the ringing in the ear, and the nephrotoxicity, which is your kidney. All right. So you want to ensure that you're monitoring hearing and your kidney function. All right. And when in doubt, if you see anything with the ototoxicity and they're talking about the medication, probably just choose that one if you're not so sure. All right, because most of the time the antibiotics tend to cause that. All right. Lithium toxicity. A client on lithium reports nausea, vomiting, and diarrhea. What is the best nurse's action? Hold the medication and notify the healthcare provider. Administer antiemetic with lithium. Encourage extra salt intake. Reassure the client that these are expected. All right, so you have a patient who is on lithium and is having nausea, vomiting, and diarrhea. All of them at once, all right? What is the best nurse's action at that time? You're going to hold the medication and notify the provider. You're going to administer antiemetic with the lithium. So you're going to give them some nausea medication. You're going to encourage, you know, the extra salt intake. Or you're going to reassure the client that these are fine. All right, which of them? A, okay. So definitely you want to go ahead and hold and notify the provider, all right? Because the patient is having lithium toxicity, all right? Sometimes they might just have the nausea. And it can be related to something else. And you probably give them some nausea medication. You know, so much when you have like the nausea, the vomiting, the diarrhea, obviously there's something bigger than the little nausea that is going on. So you want to hold the medication, let them know, and then from there they can go ahead and check their levels to make sure their levels are not too high. All right. And then when you have the diarrhea and all of those things, you're thinking about losing all of those electrolytes. So you don't want to complicate things too much and just constantly have the patient, you know, be taking the medication and having all of those symptoms or signs. All right. Which medication should the nurse anticipate administering for an opioid overdose? Without me giving the answer, which one would you say? So for patients who have opioid overdose or narcotic overdose, what medications do we give to reverse it? Naloxone, okay. And YT here, which medication do you say? Malden, naloxone, okay. Nice. So definitely you have your naloxone, your vitamin K, protamine sulfate, flumazenil. The answer is going to be your naloxone. All right. Your protamine sulfate, what do you use that one for? I figure more or less, mommy. I figure more or less. Your protamine sulfate, that one, what do you use it for? Heparin, okay, nice. And then the vitamin K, what do you use that one for? warfarin. And then your flumazenil, which one do you use that one for? And we're talking about in terms of the reversal. Warfarin. So most of the time when patients are on any form of benzodiazepine, then you'll use that one to reverse the effects of it, you know. So definitely if they are on, hold on there. So if they are taking any form of the PAMs, so like your lorazepam, okay, so you can use it to reverse sedation or respiratory depression caused by a benzodiazepine, usually after a procedure or any form of overdose. So if you have a patient that comes in with, you know, your Xanax, your lorazepam, diazepam overdose, then definitely you'll use the yes, you'll use the flumazenil for that one, for the reversal for that agent. All right. But the Narcan or naloxone is the one that you use for your narcotic. A client prescribed lisinopril develops a dry cough. Which is the best nursing action? Continue the medication, discontinue and notify the provider, increase fluid intake, administer with food. So the patient comes in with lisinopril and has a dry cough. What would you do with that patient? A lot of times, you know, we tend to hear people say that, oh, I'm having, since I started taking this medication for my blood pressure, I just have this lingering cough. They're having a cough for months. So what would you do for that patient? It's a common side effect, but the patient is just complaining about it and they can't deal with it anymore. You understand? They're tempted to just go ahead and stop. So what would you do, you know, for that patient? So would you continue the medication, discontinue and notify the provider, increase the fluid intake, or administer with food? So based on the 4 answers here, they said to discontinue and notify the provider. But usually if you're able to titrate, you know, taper the patient off, that's what we encourage. Try to find, you know, something that the patient will be placed on, and then from there. But continued medication is a no-no. All right. Based on the answers you have here. Increase fluid intake, administer with food, no. ACE inhibitors can cause a dry cough, and so a lot of times you want to switch them to something like, you know, the ARBs, the losartan, all of those medications, to see if, you know, that will work out for them. But the dry cough is a thing that a lot of patients tend to be administered with food. A lot of patients tend to complain about. All right, so you just need to switch them to something else. All right, and I'm gonna do one more. One more. All right. Who did that one? Which order should the nurse question? Oh, the answer is to discontinue medication and notify the provider. Yeah. So which order should the nurse question? A patient who is receiving morphine for post-op pain, meropenem for sickle cell crisis, oxycodone for fracture pain, or hydrocodone for cancer pain. So which order should the nurse question? All right. Morphine for post-op pain, meropenem for sickle cell crisis, oxycodone for fracture pain, or hydrocodone for cancer pain. Meropedim for sickle cell. Okay. Do we have anybody else with another option or answer? Yes. Do we have anybody else with any other answer? So I know a lot of times, especially when I was in Jamaica, we tend to give our patients, or sickle cell patients, we used to give them a lot of pethidine. It's the same thing as the meropedim. All right, but we know that it's not working, but you still give them because they say it make them feel better. You understand? But it's not the right thing. A lot of times you might hear hydroxyurea is something that they used to treat sickle cell with. All right, so a lot of patients will tell you that that works really good for them, but the meropedim or the demerol or pethidine, it doesn't do anything for sickle cell. All right, it doesn't do anything for the sickle cell. So that one you definitely want to question. Morphine for post-op pain, definitely. Oxycodone for your fracture pain is okay. Hydrocodone for your cancer patient, that is fine. Meropedim is not recommended because of the toxic metabolite meropedim, which leads to seizures. All right, but how do you go about with managing your sickle cell patients? Yeah, how do you manage your sickle cell patients? So if you have a patient that comes in, you have a patient that you're taking care of, and you're suspecting that the patient is in crisis. How would you go about with managing that patient? Your fluids, So you always want to, do their fluids. So let me see, sickle cell patient management. So you always want to do your fluids. A lot of times they'll do the blood test as well to look to make sure that the patient is really in a crisis. So that's a good thing about here. Sometimes the patients will do come in, and rarely do you see the patients coming in with sickle cell crisis, So once they say that, oh, they're a sickler, then we tend to go ahead and do their blood test to confirm if they're actually in a crisis. But most of the time, the patients will be hanging out with their fluids going. They'll give them a little bit of a pain medication, and that's it, just to kind of hold them off for a second. But then, definitely you want to start with your NSAIDs. All right, you want to start with your NSAIDs. So anything like your Aleve, your Motrin, ibuprofen, that is what work for them. All right. And then eventually, if that is not helping, they will escalate to your narcotic. But sometimes the doctors just kind of cut it and just say, okay, then a small amount of pain medication, start high because they say that they're having pain, and then from there. But they'll also do their IV fluids, which is going to help with the sickling of the cell. So you want to ensure you're flushing you're giving them a lot of fluids, all right, to flush out and preventing that occlusion there that is going to cause the reduced blood flow and with the cell itself, the C shape, because they tend to kind of hook together and cause the flow of the blood to be slowed. All right, and then you want to make sure you're giving them some oxygen to prevent any form of hypoxia, because their cell is already C-shaped, so they're not carrying enough oxygen, So sometimes they tend to have like a little chest discomfort, so you want to watch out for those patients as well. And then you want to find out what is the triggering factor. So they sometimes will go ahead and work them up for fluids prevent clotting. Yes. They will definitely go ahead and work them up for any form of like infection, dehydration. And a lot of times, sometimes, when it is cold, you realize that they tend to have a little bit of a sickle cell crisis as well, because remember, the cell is already C-shaped, and the time is so cold, their blood is slowed down, and then just think of it, the blood moving so slowly, and then all of those little C-shaped cells, clumping together and causing reduced blood flow. They tend to have the chest pain, the pain in the joints and everything. And then you want to monitor for your complications as your ACS. So your acute chest syndrome. So a lot of times, you know your patient coming in, and even though we know them as quote unquote frequent flyer, you have to be careful. You have to be careful and still do the full workup on them, because you don't want it to be a case where you miss their, their acute chest syndrome, that ACS that is going on. You don't want to miss it because you're just thinking that, oh, they're just a drug seeker. All right, so make sure you're giving them a lot of fluids when they come in. Start them on their pain medications, do their appropriate workup, and from there. All right, but Jamrock RN, welcome. Chelsea, bless, welcome. Thank you so much for tuning in. And if you haven't followed me as yet or subscribe to my YT page, go ahead and subscribe on YouTube at ThinkNursing. The full length of the live and the other videos that I've done are uploaded there, so definitely go ahead and check that out. I have a lot of information regarding transitioning as an international nurse. So yeah, there's a bag of things going on YT, so definitely go over there and subscribe. You can ask any questions or any, if you have any concerns, you can always ask me, and then from there I'll answer. All right, but it's 9:36. I think we've been on this live for what, 2 hours, 2.5 hours, and it was a good live. So definitely we will meet up back again in the next few days. We'll try to do Tuesday as well, and Thursdays we'll try to do a few questions, and then from there, but I'll try to do lives at 7 o'clock during the week, but I'll do the study session probably like on Tuesdays and Thursdays. All right, and if you want to be a part of the small group, you can always go ahead and inbox me, and then from there we can have a little discussion. All right, but I really want to thank you guys for tuning in. I really appreciate you taking the time out and be so active on the page. All right, but anyways, I am gonna head to my bed. It's 9:30. I'm trying to keep my schedule, real good when it comes on to sleeping. Working on that. Chris Tavares, thank you so much. You're welcome, Shiny Eyes. Not a problem. Who is sending me a link? I think Chris is probably just passing through. Yeah, so no problem. Join us next week, or join us, I'll pop up every now and again, some random times, so definitely I will be here. You can't sleep, Shiny Eyes? Why? I'm not really feeling sleepy though, usually I try to go to my bed early, but sometimes early is like probably 1 o'clock, 2 o'clock. I'm still up. And then by 5 o'clock, 5:30, I am up again. You understand? So I'm gonna really sleep that. I'm working on it though. I'm working on it. Not a problem, mommy. Not a problem. Come back and tell us how things went. Me always tell people, I know you already said it, that you'll be having exam when, but you see, for me, I don't really tell nobody anything. You understand? Because sometimes I put extra pressure on you. And they put extra pressure on you. So I try to not really say anything. They'll know I'm gonna do the exam, but I'm not going to tell them, say, oh, it's next week. Because guess what? Everybody going to call you. Everybody going to call you before the day of the exam. You understand? That's just it. Oh, menopause. Okay, I'm sorry. I know, I'm sorry. Yeah. 2 and 3. Yeah, that's my time. But I know you will do well. I know you will do well. As I say, and just whisper a little prayer. You understand? Just whisper a little prayer when you go in, and just be positive, and I'm sure you'll come out with the results that you want. Don't rush through it. Don't rush through it, and don't, be there saying, is it gonna cut off at 75? My exam cut off at when we done the entire exam. You understand? I honestly wasn't 100% prepared because I was coming over, and I was like, okay then, but I wasn't 100% prepared for my exam. And when I went in there, like, this was me. I was kind of just laughing it out because I was like, okay then. But I did the entire exam, and that's just it. And when I left the exam room, I never really feel as though I failed. I was like, if the exam, if the exam was supposed to cut off, it would have cut off a long time ago. But I feel as though it was kind of, me getting one wrong and then I get another one correct, that kind of way. So I did the entire exam and I never really feel any way about it. So I don't study, I SWAT. What? No, don't study, don't SWAT. No, I study. So just like how you see me reading, I try to go through each of the answer and just have a little idea about it as to why probably that one wouldn't be correct. And if you have that kind of concept, you know, going in the exam, at least I feel as though you'll cover a lot of bases, a lot of topic during the time when you're doing your questions. But if you're just going to go there and be like, oh, the answer is A, and jump on to the next one, then there's a high possibility you're not going to get, you know, a really good study. That's how I feel. So you do past papers. That's what I do. I do past papers, but at the same time, I try to look at each answer and see why it's not that answer. So that way, in the event that the question comes back looking similar or with the same, you know, in terms of the concept, at least I would have had an idea from my previous question and be able to answer it. So it helped me if I read and I can't remember at all. Okay. Well, I have to read and write at the same time. So you have persons who do that. So that's me. I write at the same time because I have photographic memory. So if I write it down, I remember to skip the page, or I try to remember where I actually write it down, and then from there. So find different ways of studying, and then from there, you know, you just own it. But leave questions, like, you know, I feel as though you should leave the little questions to the end, you know, a couple weeks up to the exam, when you feel as though you've gathered like a lot of information. You know, you read out your textbook and your textbook is pretty good with a lot of information and you understand it, then definitely go ahead after and do your questions and answer session. But don't rely solely on the question and answer, because I don't feel as though you'll get adequate amount of information from that. And then not only that, sometimes you might have persons who do those review courses. You know, sometimes if you're not reading broadly, you might find yourself just focused on, you know, or you become so narrow-minded because of something that somebody else had said. So if you take up your textbook and you read and just have a broader knowledge, then it's better for you later on, because you're able to explain, you understand the different rationales and not be focused on, you know, the one thing that I regurgitated to you 15 minutes ago, and you're going there thinking that that's the only answer. And probably what I said is not the only answer that is there, and you go in the exam and there are other options there, but you're so focused on what I said because that's the only thing you have in mind in terms of what you've studied. And so the answer is right there, and you can't even probably choose the correct one because of that. So I always tell myself, read broadly, spend the time and read, get the concept, and then you can always go and do your question and answer later on based off what you've read, you know, before. So that's just it. Yes, if I write it helps, but not reading. Okay. So definitely everybody have their own way of doing things. So as long as you retain it, and as I say, you don't want it to be a case where you're just passing the NCLEX. You want it to be a case where when you pass the NCLEX and you go out there and they ask you something, at least you have an idea, you know, so you're not only just prepping yourself for the NCLEX, but for the real world when you get out there. So that's just it. All right. But anyways, I did say I was going to go to my bed. All right. So thank you so much. Thank you so much for tuning in. And I will see you guys. Yeah, I did enjoy my live. If you enjoyed the live, just tell me. Just tell me. Just say the live was good, so I can feel motivated to come back next time. But either way, I'm going to come back because I know you guys enjoyed it. All right. Well, enjoy your evening and get some rest, you know. I know it has been a long day. Share info so we can follow. Oh, like my YT page. My YT page is ThinkNursing. It's one word. It's one word, ThinkNursing. And then you can follow me here on TikTok. All right, you can follow me here on TikTok. And as I say, I'm gonna have like I'm trying to do like a 3 months series. So I'm gonna do small groups. So depending on the amount of persons that, you know, show up, I'm doing 5 or 10. I'm trying to do probably like 10 persons. I'm giving away some free spots. So definitely it's gonna be pretty reasonable. You know, it's gonna be pretty reasonable. But I'm giving away some free spots. So depending on who inbox me first, then you guys can actually do like a 3 hour. I'll try to do like 3 hours one day with you guys, and then from there. So I'll do 3 hours per day, not per day, like at least once per week with, you know, each batch. Or if you want to go ahead and pay for whatever it is, then you can always do that with me, and then we'll do that for 3 months and see how it goes. I know the US is expensive. Do you think it's worth it to migrate than staying in Jamaica? Depends on, what you are, why you're migrating, because you have some persons who already have things kind of solid in Jamaica. So if you don't have your student loan and you feel as though you're getting adequate amount of money, you're able to buy your house, your car, things like that, and you're able to work with it, it's working out for you, then I want to say you need to really, but it depends on you understand, it depends on you and your obligations, your responsibilities. But in terms of opportunity, like if you're looking to, advance your career, I'm not saying you can't advance it in Jamaica, but there's so much more opportunities here in terms of nursing that definitely you can take advantage of. So if you're looking for more opportunity, like there's so much here, you understand? So it depends on why you want to migrate. I migrated because I needed the opportunity. You understand me? I'm a student loan and I have other things that I want to do. So I decided to migrate. But if you are already making a lot of money and you feel as though your situation is okay, you can survive and everything is good, then I would say it's up to you. So I'm not gonna say that I want to come back to Jamaica. I want to go back to Jamaica. You understand? But I don't want to be working Jamaican dollars. That's just how it is. But I really want to go back home, if possible. Think nursing, is that a call comes in and disrupt the life? Huh? No, there's no call coming in. There was one on my other phone earlier when I had paused it. Is it think nursing a call coming in and disrupt the life? Shiny eyes. Is it think nursing? Oh, think nursing. Yes. So on YT, it is think nursing. So one word. And then you can follow me there. And I talk about my background growing up in Jamaica and all of those things. So yes, there's a ton of things over there to keep you, a little bit occupied on my page. So definitely go over there and just watch and subscribe and share it with your friends, your family members, things like that, so they can be a part of it as well. Well, thank you so much. All right. Well, I'm gonna go. All right. Enjoy your evening and I'll see you. Oh, I'll probably do a live tomorrow in the day. All right, because I'm not working tomorrow, so I'll be doing a live tomorrow in the day, but I'll put it up at the top as well. You're welcome. All right. Oh, let me do the clap. It was a good live. I figured it out. Always hear it and I never know how to find it. All right then. Well, enjoy your evening now. All right. Bye.